The May 15th meeting of the Universal Health Plan Governance Board. Thank you all so much for being here in person. We're really excited about today's meeting. It's kind of like a refresh and a restart for the board. So let's get started first with our roll call.
Sorry, just one, yeah, I understand, just one second. All right, Helen Blanca,
Here.
Chun Wei Chi, Amy Fellows,
Here.
Michelle Glass,
Present.
Bruce Goldberg,
Here.
Judy Richardson,
Here.
Cheryl Ramirez,
Here.
Mary Lou Henrik.
Here.
Excellent.
Great.
So we're sorry, we did have a little trouble with the apologies for the meeting. We thought we were going to be able to use that. So we're a little bit MacGyvered, so we may be hindered, but if you just want to yeah.
Turn video off for the room.
It's just as the blur background is on, so only like right now, only Mimi's showing, and a second ago, only I was showing.
There we go.
Thanks.
Thank you. Great, so first order of business, I want to officially welcome Mimi McDonald as our new executive director. This is her official board meeting.
Thank you.
We're thrilled to have you. It's been kind of a whirlwind months getting up to speed, but it's been great. I'm really excited to have her here and get started. And then Mimi, would you like to introduce Isabel?
Yes, I would be delighted because even more important coming on is having a new executive administrative assistant, which is Isabel Cordelis. So yay for Isabel and yay for Jamie. Yeah. Oh.
Okay, so for the record, Sunway has joined us and
Duly noted, thank you.
excellent. So a quick agenda overview. We have a really exciting meeting today. We're going to start with the visual tour activity just to kind of get on the same page, to get settled in this in our objectives for the day. We're going to quickly review our mission, values, and principles to ground ourselves in those. And then we're going to have an overview of our consultant deliverables from our staff. Then the bulk of the meeting is going to be spent doing an update on our work plan. The main focus of today's meeting is to clarify and recommit to the strategies that we've agreed to ensure we're headed in the direction we want to head, and that the work that's coming up in the coming year will get us there. So that's going to be the bulk of the meeting. We're going to have a break for lunch, and then after lunch, we're going to do a summary of sort of what we've compiled in the morning, set some priorities, and then we have a guest speaker. Former Governor Kitzhaber is going to be coming to talk to us a little bit about his insights into our work and our strategy, and that should round out the day. I'm really thrilled that Judy and I are co-facilitating this meeting, particularly because she actually knows how to facilitate. So she has a facilitation process that she's going to talk us through as we get to that. But first, we're going to review the public comment. It's been 2 months since this board has met, and so we've had a lot of public comment come in. I'm going to go through them quickly, and I always think it's really interesting, this portion of our meeting, to hear what folks in the public are noticing about our work, and what their questions are to us and what their comments are. So Aaron Murphy, Susan Crawford, Molly McDonald, Aaron Murphy, Cheryl Mickelson, Richard Gibson, Simon Schaefer, Susan Morey, Katrina Miller all wrote in to just express general support for our work. Ari Sim wrote to express frustration with the current healthcare system and express skepticism that we will be able to deliver meaningful change. Jerome Prosperi expressed support for separating health insurance from employers and cautioned us against the use of AI with private healthcare data. Melanie Griffin also expressed support for separating health insurance from employers, as she works for a nonprofit that keeps changing insurance plans to get the lowest cost plan possible, which means she cannot get consistent care. Lisa Shaw expressed concern about the increase in taxes from this work, stating that Oregon taxes are already too high. Anon First wrote with concern about the role of PBMs, pharmacy benefit managers, in the insurance industry. Tyler Tucker wrote to suggest that we consider using AI in our work to facilitate it. Wendy Schwal wrote to encourage us to cover doulas as a health equity issue, and Jacqueline Naganuma asked us to include gender affirming care in the plan. Ashley Warner wrote in with a bunch of questions for the board. She's a nurse practitioner living in and licensed in Oregon, but only sees patients from other states through telehealth and wonders how the plan will affect her. Gail Mensko inquired about how out-of-state care will be covered when needed specialists are not in Oregon and people need to travel to get the care that they need. An anonymous person wondered if the premiums currently covered by their employer would now be paid out of pocket. Carolyn Greenlaw asked if the plan would cover the cost of a hospital birth. David G expressed confidence that we have enough money in the state to cover everyone through a tax on businesses and higher earners. He had a quote in his testimony that I really liked. He said, "The average Joe shouldn't have to pay out the nose to get their needs met." Daniel Herrera is a U.S. Army veteran who's from Texas. He has never lived in Oregon, but currently lives in Germany, and says the main reason he lives abroad is for the universal health care benefit. He said he would move to Oregon if we're successful with our plan.
Watch out, just watch your step. Sorry. Tripping hazards around here.
So our first point of business is that, as you all know, we now have an open board seat. Unfortunately, Debbie Diaz had to resign from her seat. And so we now have an open board seat. So the application process for this board is open, meaning anybody can apply at any time. There aren't like starting and ending points. So I want to encourage everyone, if you know folks who may be interested in joining the board, please encourage them to apply. That's through the governor's office. And if you need information on that, you can email us. We can help direct you to that site. And I want to point out that Debbie was the chair of the Plan Design and Expenditures Committee. I've stepped in as interim chair of that committee, but that's something I would like to pass on. So currently, if we can show the current,
Oh, you know what? I apologize.
Okay,
Is the open board seat on our website so we can easily like share it with people?
Yeah, I apologize. There's a, currently in the, what we posted here is the link where people can, make do their application through Workday.
Mhm.
And then we're gonna work with our IT staff to have kind of a banner and a link so people can, yeah.
And,
yes,
and Helen, you clarified to me, and I went back and looked at the law, and that this is one of the kind of connected loosely somehow to healthcare.
It is a healthcare.
it's a health,
Yeah.
that's right,
But it also says when you read those things, it could be public administration.
yes. So this board is comprised of 5 healthcare seats and 4 public engagement seats.
Okay.
And the seat that's vacant is a healthcare seat, which means we're looking for somebody from the healthcare industry, healthcare financing, or public administration, could fill the seat. That's right.
Okay, thank you.
So I just wanted to, so right now, I believe Chunwei and I are the only ones, the only board members on the plan design committee. Chunwei, I wanted to offer to you if you were interested in taking over role as chair.
In this public forum.
Right.
Advance committee take a lot of responsibility.
Okay, I just wanted to,
And also I have one more issues because we have a heavy teaching and I don't get to choose what I teach.
yeah.
And for example, this time I was not able to attend finance. And I don't know what happened in the program. So I think it would not be a good idea, given my situation, I have no control of my time.
Right.
The only time I say absolutely no class is Thursday morning.
Okay. Okay, and we appreciate that. So I just wanted to open it up if anybody is interested in joining the Plan Design and Expenditure Committee with the express purpose of being its chair. That would be great. You can belong to more than one committee, or you could leave the committee that you're currently on and join Plan Design. Either one is fine. Otherwise, if not, I will continue to serve as chair, but that's not ideal. So I'll open that up now, or you can think about it. If anybody's interested now, we could make that switch. Or we can just, or do that at our next meeting if you want to think about it. Any interest?
Interest but not management.
Yeah, no, same.
Bert says yes, the calendar says
Okay, well, please continue to think about it, and maybe as we recruit a new board member, that person might be interested as well. Just as a reminder about the process, people could apply anytime, but the new appointments wouldn't happen until September. I think from the governor's office, with confirmation and probably starting in November. So we've got the summer and the early fall.
Well, people really, they need to get their applications in, and I'm sorry, because I have a slide for that, which we'll post a little bit later. I think it's by the end of June.
By the
So
end of
there's,
June.
yeah, so there's a finite amount of time that we
Oh,
need to
okay.
recruit people.
So spread the word, let people know, let's get another great person in. Okay,
Could I ask just
yes,
could you just scoot over a little bit, Helen, because I'm trying to kind of sit there. Thank you. That helps. Thank you.
Yes.
Really important
I sit
question.
where- I sit where-
I can sit back in my chair now, thank you.
Okay, great. Okay. Great, so now we're gonna move on to this visual explorer activity, and I'm gonna ask the board members and Mimi and Kim, you're welcome to participate if you would like to, or you can sit it out, but certainly all the board members. There are a number of cards sitting at the front of the room, and I'm gonna ask everyone to get up and just browse those cards and take a look at them. And your purpose is to pick 2 cards to answer certain questions. The idea with these cards is that they help articulate a little bit deeper than we usually use with our words. Sometimes we just talk and say the same words over and over again, and sometimes getting at a certain issue requires getting at it from a different way. And so we use Visual Explorer cards to kind of help deepen the conversation and get a little bit more clarity on what we're thinking or feeling. So the first question that I want you to answer with the cards is, how are you feeling about the board's work at this moment? Which card, which image best represents how you're feeling about the board's work at this moment? And then the second one is, which photo best expresses what you think we need to focus on in the year ahead? What do you think is the most important piece? With the cards, it's important to go with your gut instinct. Maybe you don't know why you picked a certain card, but just the image just kind of speaks to you on that issue. So just don't think about it too much. Just look at the cards and grab the one that's, so again, 2 questions. One is, how are you feeling about our work at this moment? And 2, what do you think is, which photo best expresses what you think we need to focus on in the coming year? So we can get up.
I know,
Oh, yeah.
I'm trying to get to the bigger screen. Sorry, go ahead. Yeah, you guys can.
Yeah, go ahead.
Please, please. You don't need to worry about what's up there.
You have to arm wrestle if you want the same card.
Very evocative, yeah.
Yeah, we need some of that.
Gotta be careful. I'll help.
Yeah.
I'm not. You have it anytime. You're trying to learn outside. Oh, perfect, I think, yeah.
Good to meet you. How are you? I'm good, how's you?
Something in person. on Zoom.
After all these.
Never mind.
Exactly, that's.
And phone. And phone, that's right. I used to. Yeah.
Know that well.
Okay, so now we're going to show our pictures, describe what we see in the picture for each question and why we chose it for the question asked. So I'm gonna ask Judy to get us started.
So how am I feeling about the boards working out? I chose this picture of the girl who's pulling someone along. She's looking ahead. You don't see who she's pulling, but you kind of see it somewhere off in the distance. And I think my feeling on where we're working out is lots of folks don't know what we're doing, we're trying to do. We're like, trust us, come along with us. We have a vision ahead. Yeah, that's where I think we're good now. And then for the focus ahead, I love this picture of kids on it's kind of a carousel that's swinging right.
Rural thing.
Yeah, and they're all attached individually, but they're all going in the same direction and they're all on board and all the seats are filled. And so that kind of contrasted to me, these two, like in the future, everybody will see where we're going, they'll be on board, seats will be filled, they understand what we're doing.
And then we also give an opportunity if anyone else sees something in Judy's pictures that you want to comment on, that you like, that you notice, that you agree with, that resonates with you in some way.
I think that when it gets to me, I chose a child picture, a girl, and I think some of it for me personally has to do with thinking about our future generations, that that's what this is about. And that we have my grandchildren and yours and all in the world, that in Oregon, somehow that hope that we can figure this out such that our children and grandchildren have healthcare that they need. So I like that. Little girl.
Yeah.
I love this. Thank you for putting together this exercise. This is great. I noticed that the little girl is pulling along one person. And I think that there are very few people that we're pulling along right now. And so that really stood out to me as there are a small number of people who are very engaged. And I think we are in this moment of figuring out what is most helpful to communicate out to that broader audience and how to do that with the resources that we have to get to all the seats full on the plane.
Volunteer to go next. Okay.
So I actually have no idea why I picked these cards.
That's usually how they work, and it just speaks to you somehow.
Yeah, so where are we now? I picked this one, which was a lot of very bright activity. I mean, and I just think we're at a place, we've organized ourselves, we have a lot of activity going on. We've got these subcommittees and they're looking at all the key issues, but it's all like the fireworks, they sort of go up, but then if you're ever at a fireworks show, they kind of disappear. And that kind of got me to my second card, which is the one with all the tools. And I guess this one spoke to me because it's about, where do we need to be? I think that we've got a lot of tools, but I'm not sure we're all clear on what we're building in terms of, I think sometimes I feel like we're headed towards putting together a report. And I'm not so sure that's what we should be doing, that I think we're putting together
plan for universal health care. And if we think about this as just a report, reports just stay on shelves. But I think we need to think about how you sort of how we use all these tools. If it's just a report, all you need is a pen. If we're building something different, I think we have to think about the tools we have and kind of what we're making. So those are my comments.
Pretty cool. The first one is kind of exciting but chaotic.
Yeah. And actually, I should put it right, so I'm not sure which is. It could go, it could actually go anywhere.
Maybe that's,
So firework doesn't matter which direction you look at.
Yeah.
I was gonna say, that tells me something about you, actually, the fireworks seemed optimistic to me. And I almost got that card with the big fire,
Yeah.
and I just feel like everything's on fire. So, but I had to put that aside because that's maybe my other hat. But so that tells me something about you, and then also you're pragmatic because you're talking about, the tools that we need, and I'm very glad that we've got more tools than just.
I think that optimism piece is really important because I think, particularly now, and I know for just speaking personally, I think, I'm often, beating up on myself, how come we can't be doing more? How come we can't be going faster? And I just think we have to, have that sense of there is a lot of bright light. And, how do we continue the fireworks show? And that's always the most disappointing when the sky looks dark, then you sort of want more.
Michelle, did you want to?
Sure. So for those online, I'm Michelle. And my first card for where we're at as a board is it's a barista pouring coffee. And the coffee is going through the cup onto the floor. So that doesn't mean I'm not an optimist. I think that to me, this speaks to a mismatch of expectations. So when we started, I think I had an idea of what this work might look like in the first year. I think a lot of the people in the community that I was talking to had hopes for what this might look like in the first year. And I think what we actually had to pivot and do in this first year was a lot of foundation building, a lot of making sure we're all on the same page, making sure we have a clear vision, a clear foundation, some dealing with some unexpected transitions. All of those things are part of the work of every piece of important work. And so I think we've done what was in front of us to do, that we needed to do to be successful. But it wasn't what any of us, it wasn't what I expected. I'll speak for myself. And I know it wasn't what my community expected. And that's okay. But I think what we need to do now, I have an owl. And that to me represents, we have, I think, a very serious, important, I would almost use the word like sacred charge to be wise, thoughtful, careful, grounded, and to be very clear and intentional in how we use our limited time, resources, and energy and focus right now to make sure that we are building the best plan and getting the most actionable feedback on that plan so that the next step of this will be supported, funded, we can keep building on that.
That owl one spoke to me too. I almost chose it, but it seemed a little too intense.
Well, I was gonna pick Mary Lou stole my chess piece, so I had to improvise.
and I didn't even see the apples.
Any other comments on Michelle's pictures?
I can really resonate with what you're saying, because being a new board member and having been one of those kind of outside people that was really intensely watching and whatever, and kind of like come on, you guys. But now that I'm here and I'm still struggling a little bit with the process and the kind of public meeting law and all of the various pieces, that there are constraints. And I think in some ways you guys have done a good job of, you know, kind of navigating them, and you're all, I think, more ready than, or prepared than I am. I'm still feeling like I'm running, trying to figure it all out as in this role, which is different than the role. So the ways this. But I also, I like that, I wouldn't, if I'd seen the brief, I would never have thought what you thought, but that is, I really liked your explanation of it.
I'm gonna go next, right?
Me? Okay. I'm actually gonna turn them around and say differently than, I mean, I picked one for the first dance, you know, but I'm gonna do it different. That's Mary Lou and a Gemini, and I sometimes do that and drive some people nuts because I kind of was going down this path. It's fine. This is back to kind of like the picture of the girl, the future, that I think, in terms of what you have done, you came in really trying to think about that future and how to make it be. But then, see mine both, kind of both ways. Okay, so this still is kind of the future. And then the chess pieces, really kind of, I'm not a chess player. I know pawn, okay? And sometimes I feel like we're all kind of pawns in a huge, kind of sphere that's out there with all kinds of people pushing it and trying to knock it off the board. And that somehow we have to kind of stay strong as we go forth and figure out, you know, those other plays that are out there and be intentional about them. I like versus tools. I like what you said, Michelle. So, you know, I'm really, I think everybody started out very hopeful and very kind of maybe grandiose in how we can just get this done pretty quickly. And then we're kind of, we're at a chessboard trying to figure out the correct moves that will get us to where we need to be. So, and I'm learning and I'm glad to be here, but I'm still feeling pretty new.
This is a strategy game, it's all.
It is,
strategy, you know,
it
so-
is, and I've had it taught to me, but I've never been a real chess player, but strategy is really important, and I think that that's something this board considers and probably even needs to keep considering at a deeper level. Every move. How does that move us to the fireworks that we want?
Okay.
So like I said, I was going to choose that postcard with the fire and I thought, oh, don't do that, you know, in the chair, like sitting there watching a dumpster fire. So instead I chose this, and this kind of expresses to me a feeling of being overwhelmed and being alone. And I feel like as several of you said, it feels a little bit isolating that we don't have a bunch of people with us yet. They don't know what we're doing, and it's just such a huge lift. So that's what I chose for that one. And then this one you could interpret maybe as jumping off the cliff. I'm going to choose taking a leap of faith. That's kind of how it's going to me. And that's, I think that's next. We just have to go there and be brave and just do it.
I almost chose that one. Yeah, but that's really the same reason.
You know, when I look at those two cards, I guess my question is, are those both sunset or sunrise?
Oh, yeah, good question.
Interesting.
What do you think?
I think the first one, I'm just going to say it's sunrise. But it does kind of look like a sunset. Maybe sunset on the old way of healthcare. Let's say that, yeah.
This is the sunrise.
I'm Amy, and my first card, I picked these bikers, but it kind of looks like to me, like I was thinking of a relay handoff, so like the task force in the first year, you know, we're picking up where they left off, kind of. And then my second card are zebras, and it represents, I mean, zebras are kind of the symbol of rare disease. And I have a family member with Ehlers-Danlos, which like the HERC is still struggling through how to cover that. So the uniqueness in thinking about like not leaving people behind because they have unique, health challenges or other things, but also that we are unique in terms of Oregon and this work that we're doing, and that we're, it seems further ahead than other states that have been trying, so uniqueness in multiple ways.
Stress, Amy, would you say that those zebras are a symbol of hope or stress? I mean, the fact that doing something unique and out of the ordinary is,
I think there's some, I don't think. I think they are more symbolic for like why I'm here, to think of people who often are left behind in our current system and make sure that we don't, that we do better.
I think also like zebra, I mean, I don't know a ton about them, but in the photo, they're in community.
Yeah.
And I think speaking to your first card, Judy, like if there's a small number of us, but I think especially with our committees, and with the public comment that we received, there's a lot of diverse perspectives, areas of expertise, that are coming in to inform this work and that have informed the task force and the other iterations of this work. And so I think that's also a hopeful reminder that this is a community endeavor, and we're in that relay race, but we don't have to hold it alone, any one of us.
Yeah, it does look like they're supporting each other.
I'm UHPGB. The first card I pick is a mountain view. And I perceive our work is like we are navigating in an ocean where we know the destination, the big continent, but we try to find where we want to land. And so the current status, the reason I picked this picture is considering we are on the ocean navigating, we send a drone to survey the land, try to find out where we want to land. And the land is universal healthcare. But universal healthcare is a big box where we want to be specific to design. And that's why we are surveying the land, the landscape, and take an aerial view. And the second picture is a lighthouse. I choose so related to that theme, that we know where we want to go and we need some guidance to help us find out where specifically we want to land in this destination. And that specific also relate to Bruce's earlier comment about the tour. And I fully agree with you that we are not developing a report. And I find it probably the more suitable time to talk about our task is we are actually developing a playbook, how to operate universal healthcare. And we need those guidance.
Like calling it a playbook instead.
Yeah, I just wrote that one down, yeah.
Because based on my experience working with Taiwan's universal healthcare, once that implemented, we do really need a detailed playbook because there's so many complex issues, you need guidelines.
Beginning at the end, and that has been kind of, as I stepped into this kind of thinking. People focused on the report, and it's like, no, it's like beyond that, and we're, do we have an agreement on beyond a report, and how that leads us to beyond, and so that's a chance, but.
We are developing the first version of playbook that's not set in stone. That playbook will be constantly being revised as we move along.
Did you guys pick cards?
I did not.
Okay.
I wanted to hear.
Okay, okay, wanna make sure. Okay, then I guess I'm the last one. The card I picked for where we are now is this person that's looking through a hole with light coming out of it. Which I do feel like it's been a rough year. We've had a lot of things to figure out and to get grounded but to me, this is also very hopeful. I am feeling really hopeful about where we are currently. I feel like I can see the light. I'm grateful for everybody who's been so committed to this work and bringing on new staff and the constant energy that we get about people who are engaged and interested in our work and want to see it through. So the more I talk about it to people, the more I can see that where we are right now is a place of hope and we can see where we're going. But I do agree that we need to, this is a power button, it looks like to me, on some sort of device. And it's sort of on the same line as tools, like we need to just get down to brass tacks and kind of come up with some really clear strategies and sort of mechanize the whole thing. We need to get our strategy in place and make some headway. So those are the two cards that I picked. Powered up. Yes, let's power it up.
It's not try turning it off, turning it back.
I've been having difficulty with my computer, it's like, it'll just shut itself off, and it's like, and then, so no, we just push the button, power it up.
And one challenge we are facing is unlike software or hardware, we don't have an opportunity to test run. When it's right, it has to run.
It's interesting, yeah. Any other final thoughts, comments?
These are a lot better than Rorschach cards.
I think it's really good, just like a way of getting at something a little bit, a little differently, so. Find them. Great, so, I'm gonna, quickly here hand it over, to, first Mimi and then Judy, but, before we do that, one of the things that we wanted to make sure to do is just quickly take a look and review our mission, our values, and our principles. To be honest, we did not have an official mission statement for this paper. But Judy and Mimi and I sort of wordsmithed one based on all the conversations we've had, based on our discussion around values. We kind of came up with what we thought our mission statement was. And so, while I don't want to spend a whole lot of time wordsmithing, we wanted to just present what we thought our mission was as a one sentence summary of what we're trying to do. And if you have comments or feedback on it, now is the time and we can make adjustments to it. But we wanted to just be all on the same page of what is it that we're trying to do. The sentence that we came up with is that our mission is to create a simplified, sustainably funded healthcare model that delivers high quality, equitable care to all Oregonians while minimizing financial burdens to individuals, businesses, and the state economy. Yeah.
Yeah, I like it, and the only word that jumped out at me was model, and I wonder if what we're creating as a system as opposed to a model.
Yeah.
I would second that.
Beautiful artwork.
What jumped out to me was what's not there, and that was health.
Oh.
And I just think our goal, I mean, I think it's there in all the little circles around maximizing health, but in the mission, I just
We just focus on the
wonder about, figuring out how to have that work.
One thing I noticed was that, we've been doing some work with the excellent, guidance of, Kim, on some, a style guide for the board. And as preparation for some of the strategic communications, work that we're going to be doing to help frame our work and I think be thoughtful about the choices we're making when we speak about populations and this work and break down jargon. So Oregonians, according to the Oregon Health Authority style guide, which we are considering adopting a lot of that, suggests using Oregon residents based on a lot of.
Instead of
Instead of
Oregonians.
Oregonians, based on a lot of community engagement, to be the most inclusive term, so. Just aligning that with some of the work that we're gonna be presenting to you all soon.
The maybe create a simplified, sustainably funded healthcare system that delivers high quality, equitable care that promotes health for all Oregonians, for all Oregon residents, while minimizing financial burdens to individuals, businesses, and the state economy.
I don't know about promote. I don't know.
Advances health, promotes health, contributes to health.
I don't know, something about promote feels like we can promote something and that doesn't mean it's equitable or that it actually occurs. I don't know, like
Supports health.
Bruce,
This is yours, where's health?
I just was healthy, the adverbs and adjectives are others.
So the other elements of this board, apologies, I didn't introduce what I was doing, I just like started writing on the board.
Yes.
So,
How about that improves health?
improves, yeah.
okay.
It was improved.
Sorry, didn't mean to interrupt you.
No worries.
Yeah. Promote just feels like it's kind of done or you don't have to go on.
Sorry, I was gonna introduce, so thanks for being game with us today. Visual metaphors are the theme for the day. We're gonna use some interactive visual facilitation like this work. You saw the reference to the agenda. I like having an agenda available so I know when the breaks and lunch are especially, so it's on the board over there.
Is this your art?
Yeah. So what I do is a graphic facilitation, thank you. And it's a pretty interactive sausage making kind of thing. It's meaningful to us in the room as we're doing it. If someone saw the poster on the wall, they may not understand the content that's captured because it's in the room. But at the end of the day, I'll take this and take everything that we've contributed to build today, make a PDF of it, send it back to Helen for review and to all of you, and it's available. This content came from the task force that looked at guiding principles. This was work that Helen and I have been working on with some input from Mimi, trying to figure out how do we pull the core principles into a mission statement. So there's a lot more content and language around these 5 core principles on the outside on the website. Those include health equity, maximizing health, which includes a population health component, fair distribution of resources, minimizing harm from costs, and community ownership and good governance. So there's lots of good details in those on the website. And then really, we talked about it on that site, the values that we value targeted universalism and we value meaningful public participation. So we've talked about those before. Anything else you want to add or change to that? Okay.
I'm just wondering now that you said maximize health up there. Is that better than improve? Or is you still like improve? I'm, open to either, but it just kind of jumped out at me there when you said, that we really do want to maximize health. Maybe not, a step to improve it, I don't know.
Maybe we hand it over to our communications folks to kind of just give it a look over and see if they have comments on it.
Yeah.
And maybe improve is more understandable, I don't know, I just, yeah, so I'm fine, but if we just looked at that.
I still feel like these are like the principles, we spent a lot of time and principles at the beginning of our work. And we're trying to sort of just re-ground ourselves in those, and it still feels like we're on this path. Is there anything that feels like we haven't spent enough time working on in our work so far that we really need to, recommit to, or does this still feel like this captures what we're trying to do?
I always have trouble with the word fair.
Yeah, I.
Because fair, and I've spent a lot of time with my children, life is not fair.
Exactly.
What does fair mean? And so I don't know, I don't have a better
I
word for it.
equitable, because fair to me sounds like even.
Mhm.
And to achieve health equity, it means that, I was looking at this Kaiser Family Foundation thing, with the Medicaid cuts. And I think it said something like, these numbers might not be exactly right, but like 13% of the population is disabled, yet, make up for 43% of Medicaid spending. And that's to keep people alive. So equitable, to me, makes more sense than fair.
Yeah. But then we also get in with kind of your general, and I guess back to the wordsmithing and how we put things out. I know equitable is
Yeah,
sometimes
it is
a
also.
trigger word, or it's not understood exactly, and so anyway, I understand the complexities of these words, so I kind of defer to Michelle and her group.
Yeah.
Well, Amy's part of that group, but I will say, if folks are interested, the meetings where we went really in depth, on our principles and had very deep conversations and had a lot of these conversations about equity and health equity, these came out of that work.
Okay.
And there is a lot more detail, so I would refer people to that. The one thing I would say is health equity is our overarching principle. And to me, fair distribution, fairness is a shared value. Equity is, I think, an outcome. Fairness is a process.
Okay.
And so we are all trying to get to equitable outcomes. But we did, after all of our discussion, land on fair distribution of medical resources, and that doesn't mean everyone gets the exact same thing.
Okay.
So I would refer people to all the context, and I'm also hearing that that's, there are some questions about that. So we are going to be taking our principles and putting them into plain language, one pager, finally, so we can definitely make sure that that context carries forward. So thanks for that conversation.
Can I add just one comment, not to wordsmith anything, because I don't have any words to smith, but just about the mission, seems really focused on systems and not on people. And we might want to just think about how what we're doing is about people, not necessarily about models or care or finances or just something to think about how we put in there.
Start with the group about systems and
Yes.
and underneath, we know it's people that we don't really know what that does.
Be something like to offer all Oregon residents an opportunity to have a health system that, something like that, like oriented that way.
And it's included almost.
Yeah, forbidden, yeah.
You all familiar with Simon Sinek's point, start with why people don't buy what we do, they buy why we do it. And so the why we do it is. This is just. Great.
Okay, thank you. So at this point, Mimi and Kim have done a great deal of work to help us understand what our consultants are doing. One of the pivot points that we're at right now is we have brought on Echo Northwest to help with our revenue strategy, and we're in the process of finalizing the contract with Milliman, who's also going to contribute to our finance and operations strategy. And so those folks, and we've had OHA on board now for a few months and have them for a few months more. So we have 3 groups of consultants, we've got new staff, and it's a little bit difficult to keep track of all of the work and how it overlaps and how it affects our committee work. And so Mimi and Kim have put together just a review of where we are with our consulting work, what we've asked them to do, and the timelines. And we thought we would review that before we dig into the work plan so that people have an idea of where the consultant work fits in. So I'll hand it over to you.
Oh, well, I'm actually, this is, Kim gets to, go through all of this.
Sure. So, as you can tell, it's not meant to be readable on the screen. This is a complex body of work. And this diagram, oh, hi, everyone, I'm Kim Yee, I'm your policy advisor. I work with Mimi and Isabel. I created this diagram to encapsulate the board active committees work plans, as well as the work that our consultants are, charged with doing. So currently we have 5 consultants groups actively working with us. Those include Echo Northwest. They were onboarded in April of this year. Health Management Associates. So we have Julian Smith in the room. Janine and Anya have been doing a lot of work since last year for the board. And then Milliman, which will be coming on in hopefully the beginning of next month. And in the next few slides, I'll briefly talk about the work that they're touching for each of the committees as well as how they overlap. And then within the community engagement and communications committee, there are 2 groups. We have one person sitting with us here. This is Patty Wentz, and then we have Artemis Consulting, and they'll be helping with the communication strategy for that committee. So this, if you choose to look at it on your materials, in your materials packet, you can, increase the size as needed to look at the complexity, but in the next few slides, I'm just gonna briefly go over what, how all of these consultants are touching. So for plan design and expenditures, we have 2 consultants working with this committee, Milliman and Health Management Associates, HMA. So as I said, Health Management Associates. Am I saying that correctly? No. Okay, great. HMA has done a lot of work for plan design and expenditures already, and then Milliman, main contracted deliverable is going to be creating actuarial modeling of the impact of universal health. Next slide. And again, for the operations work stream, we have HMA on board, and Milliman will be helping out starting hopefully next month. And operations is focused on tasks that a lot of other committees are interested in touching too. The Finance and Revenue Committee and the Planning and Expenditures Committee have expressed a lot of interest in the tasks that are housed within operations. And so one of the things that we're hoping to do going forward from this meeting is Mimi and Isabel and I are going to facilitate a lot more communication during those monthly meetings, committee meetings. Yeah, I see Mary Lou understanding exactly what we're saying about what the different committees are doing that touches everybody's work. So the deliverable for Milliman within the operations work stream is to do a lot of background research and presentation to this committee. One of the ones that I'm really excited about for Milliman to tackle is an administrative structure and cost piece that a lot of committees have expressed interest in. Okay, next slide please.
So Kim,
Yes.
is the OHA involved in the operations regarding the waivers as well?
So HMA's actually done most of the waiver work on OHA's behalf.
So, but we do partner with OHA as part of the legislatively required role that they're involved with us to ascertain and help us with the waivers. So we have the benefit of their expertise as well within OHA.
Thank you, Helen.
Yeah.
They're not represented here because they're a partner on it. So, but thank you for pointing that out. Yeah. Finance and revenue gets the most complex overlap with our consultants, HMA, Echo Northwest, and Nolan are helping. So we see a lot of overlap in everybody's tasks that they've been asked to work on. Echo Northwest is presenting to the Finance and Revenue Committee next week. They have a delightfully organized timeline and work plan and explanation for the Finance and Revenue Committee, where they'll explain how their work will dovetail and feed into the women's actual work. Okay, next slide, please. And finally, we have, finally but not least, we have community engagement and communication. The scope of work for both Patty and Artemis Consulting is being figured out, and we're really hopeful that community engagement and communications committee can partner a lot more with the different
committees work.
Yes.
So that, yeah, Michelle can probably explain that during lunch if you choose to. Okay, thank you. That is, and are there any questions for me? I encourage people to review the graphic if they choose and approach me or any questions in the chat. We wanted to keep it brief, but we wanted to show that we have consultants mostly on board now. Milliman is coming hopefully within the next month. And we're thinking carefully about how everyone's working, how all the communities current and future work. Michelle.
Thank you so much for this, Kim. This is really helpful. The one thing I would just encourage everyone to think about is as we are finalizing the contracts for Patty Wentz's strategic communications work, and also as you all are adjusting and fine tuning your timelines as the work moves forward, think about anything that is going to be shared as needing strategic communication touch point. We want to figure out what that workflow looks like between our committee and your committees. And so as soon as draft plans become ready, like even the plan language itself and how we describe what finance and revenue works, how we describe how the plan is designed, that is something that is going to go out for public engagement, right? And so we would love to hear from you in terms of timeline and process, what those opportunities are. So this is going to be really responsive work for us. And so we have to figure out where to put that in our contract and in our timeline for community engagement and communications to work with our consultants. But there is no siloed work that doesn't touch strategic communications when it comes to this work, as you all know, and as we've been talking about since the beginning. So would love your feedback on that. And you'll probably get some reach outs about that in the coming weeks. Also, I just wrote down delightfully organized. I love that phrase. That sounds wonderful to me.
All right, so what I have done is, and I want to make sure that you can see that it says draft timeline. I wanted to be clear that people understand that some of this, because as I think the role of the executive director a lot, as I say, is that I am not in charge of the destination, but I am in charge of making sure there's gas in the bus and that we don't go off a cliff. And sometimes I will put my foot on the accelerator. So to that end, and you'll notice, this only goes to September 2026, but there are some contingencies about some of the work between committees. And so this is very, very loose kind of first draft. And of course, things will end up changing, but kind of the work between the investigative portion, which we're really, which committee members are doing on their own, and then also that we have all of our teams of consultants to kind of bring the content that people want to deliver. And then there's the committee deliberations. All right, well, is this how we want it to go? Then up to the board. And then, of course, you will notice now there's a big piece missing here, which is all about transition. Not just because I would have run out of room, but because I feel like that's going to take, one, that should be overlaid on all of this. Right, because all of this is going to be part of the transition. So that's why there's a lot of empty spaces. But as we go along, what I hope to do is fill in all of those empty boxes. So like, as Mary Lou was talking about, like, we know the report is not the end. The report is the beginning. So like I said, this is very, very preliminary. I use some of the just from the timeline, so from our consultant groups. And then, there is a report too. And so I feel obligated to remind folks every now and again. And so there will be some of that process. But again, I want those empty boxes full. And that will take some of the work that's going to happen today, which I'm excited about, and which will end up changing this. But just wanted, that was what we were hoping to share. And I'm super excited for today. I will say, I can't say how much I appreciate all of the people who are here. You all are taking a tremendous amount of time out of your very, very, very busy lives to do this work, volunteering. And I definitely hear the feelings of, it feels like it was very bumpy, and perhaps there were some things that have slowed down, but I also hear like all of the energy and the passion and everything else behind that. So I'm just delighted to be able to be part of this work and really motivated to help keep it moving forward. So anyway, sorry, that's a little, yes.
Either can you blow this up or do you have it somewhere? Because it's not.
Yeah, it's not in the packet. Sorry, it's gonna be added into the next packet. Sorry,
Okay.
or not the next packet, but into the
I
end
just can't
slides.
read it.
No, I know.
And the
And
different
again, this
colors
is a little bit, it is pretty, no, it will go into the final notes for sure.
Here too, we can get, this document and then the one that Kim prepared, sent out email. to all
Separately?
the Members, yes.
Yes, absolutely.
Instead of just posting it, let's, send it out so that people.
That sounds
That'd be
great. I
great.
think that will be, yes, it'll be a
Yeah,
little bit
yeah.
easier to,
I like that idea. That makes it easier.
yes, absolutely. Okay. Yes, we will absolutely do that. I can do that today. All right, I'm gonna stop sharing now.
I guess I have a question. And when I'm able to see it more in depth and whatever, but about the Milliman folks. And that contract, I have in the long past worked with Milliman. I think they're a very good firm and this will be great. My only kind of generalizable statement about actuaries, and I've worked with several different ones over my career, is they really do predict the future based on the past. And since we are transforming and it's really hard, we don't exactly have a past that we can go, oh, yeah, this now we'll just predict this forward. And so I'm hoping that we give them that, that this really is different. And this, so they can't just rely maybe a little bit on their usual way that actuaries kind of see the world. So that's my little piece of, I think they're excellent. I'm glad they're the group that's selected. But we all need to kind of keep thinking we are really transforming things. Things are not going to be just a little tweak on something here. And so it is hard for all of us and for even consultant excellent people to always kind of be thinking, you can't just kind of take this and say, oh, yeah, well, 10 years from now, this is, we expect these same things.
Yeah. Mary Lou, that's a great point, and it's a great segue to the next section. I'm gonna make sure maybe has more time to see that, but that is part of what we're trying to do today is define what is going to be different. We can't just take what we've done in the past and kind of propagate it forward and just predict costs. What is going to be different about the future and how would that impact costs? And so starting to think and develop the parameters of what that future system looks like is a piece of work that we haven't spent enough time on, I think, in the board and kind of like articulating exactly what that's gonna be like. That will help our consultants, it'll help our committees, it'll sort of guide the work over the next year. And so that's the piece we really wanted. That future state of what those parameters are is a piece that we're gonna hopefully get to here.
And it's hard and it's kind of scary. I think for me, I kind of, really want this new thing. But when I really think about all the pieces that are already in place and pretty well glued to the ground, to think, oh, you gotta change that, that piece cannot remain the way it is. And there are people who are dedicated to having built that piece and kind of are nervous about, us saying no. So I just think this task is, you've got to look at the past and look at all the costs, look at all this, and I feel that sitting even on Finance and Revenue Committee, that's, we're trying to get a picture of like how much has been spent and where does it come from and all that. But we're building something new too, so anyway, I don't ramble on here.
And nope, that was it for me. So just gonna email these all out to y'all.
Yeah, so we're just talking about when is a good time for a break. We could take a break now for 5 or 10 minutes, or we could get started on just kind of giving an overview of the gap analysis work and then take a break in about 15 minutes or so. And we're gonna have preferences for now versus 15 minutes. Now, okay, perfect.
Later.
Okay, we'll see later. That's okay. Anyone else? Okay, let's give a quick overview of the gap analysis. You wanna?
This up there.
Okay, no. So this is the work that hopefully people are familiar with because of the homework that we had to do. So if you brought yours with you,
Thank you.
if you brought yours with you, now would be a good time to pull it out. If you didn't, or any references, I think they're in the email. And then we have the document that with the deliverables that everyone has copied of.
This little place.
Oh, okay.
Right.
Don't worry if you didn't do your homework, but we reviewed all of your homework and that content is gonna go here. And the point of this is to allow the committee chair to explain.
Oh, State Patrick, yes, and then.
Do you get the Wi-Fi? Thanks for your patience.
That's your beautiful part.
You fit there. Thanks for your hard work on the homework, everyone. Really appreciate that. So what I've tried to do is compile elements of process steps that you each described, and those stepping stones, those things that if we can accomplish in this work, stand independently and separate even from our end goal, which is great. It's like a win-win, right? They may take a little extra effort, but this is an opportunity to explain what those are and bring everyone on board and collaborate even potentially with other committee chairs. First place I'd like to focus, and we won't spend a lot of time on this, but is our current state. And many of you wrote about the chaos, the cost, the trouble with access, inequitable healthcare that describes the current state of trying to access health resources in Oregon. And I put here cost and sustainability as a cliff, because we will hear more about that this afternoon from our guest speaker. But what I would like to make sure we highlight in this cliff with the road that goes to the cliff are those particular elements that your committee is thinking this is a pain point in Oregon healthcare now that we really need to get better. Yes, a universal health plan is our goal. We'll talk about that in a minute. But what are those pieces for either communications or operations or finance or plan design that are really just that little piece of sand, that rock in your shoe that we need to think about, and we'll think about if there's a way to make a pearl. Anything coming to mind? And if not, we'll go into the next bit. Anything pop into mind right
Well, unsustainable costs.
Yes.
But as number one, I mean, we just had reports this month about the hospitals in Oregon that are at risk of going under because of unsustainable financial situations. And so unsustainable costs across the system, but I would
Yep.
say especially that threatens the viability of hospitals.
now?
And the financial burden of healthcare costs to families has to be on there too. at the
Yep.
top.
Thanks, Helen got us started really describing what the cliff is. Yeah, Amy.
Uncertainty of federal
Yeah.
programs, Oregon having done an excellent job of drawing down the Medicaid match for the last several years, feels a little scary right now.
Uncertainty via the feds. Yeah,
Fragmented.
yeah.
Care, inaccessible care.
One of the things that the finance committee, and I've just kind of come into this, but is about the high administrative costs that are out there, both on the provider and the payer side. And trying to get a handle on how much is that, and therefore, if we didn't have that, how much would we save if we could put it towards
Yeah,
other stuff?
I would say administrative costs and complexity.
Yeah.
Yes, yes.
It's multiple payment, multiple records, multiple eligibility, multiple credentialing, multiple referral, multiple case management, multiple quality. I mean, you could just go on and on and on and have, you know, we just have a multiplicity of all of those components within that.
Thank you for that, Bruce. You don't see that, but I put multiple redundancy, but in a bad way. Sometimes in healthcare, we want redundancy in a good way, right? But that's
Bad.
waste, right?
Yeah.
Yeah.
Centering people, again, one of the impacts of all of these things we're talking about
Yeah.
for people is a lack of trust in the system,
In the healthcare system.
in the healthcare system and in government.
Yeah.
No, go ahead.
Our current system still has large health disparities
Yeah.
due to a racist and ableist system.
Mm-hmm.
Not just disparities, we have bad health outcomes.
Yes.
Yeah.
We aren't studying in the,
We spend the most, have the worst outcomes.
yeah, it's.
I would also add, because healthcare providers and everyone who works in healthcare are people too. And that the workforce and the challenges on the healthcare workforce is
Yeah.
Yes.
tremendous.
Right.
And a lot, not all of it, but a lot of it is due to all of the things that you all have mentioned.
The Universal Health Plan, or the Universal Health Plan, the Oregon Health Policy Board had a provider focused meeting recently where that testimony was so powerful, laying out the challenges, especially for primary care providers.
Yeah.
But I would say like one thing the current state is doing well that isn't helpful is delivering profit. for very small,
Getting rich.
Yes.
generating wealth for corporations
Yeah.
and large entities.
Would you say that's misallocation of profit or how?
It's what it was designed to
Yeah.
do. It's
Yeah, fair.
extracting profit.
Yeah.
Yeah.
Capitalist.
Yeah.
System of
It's
concern.
really what it was designed to do.
Yeah.
So it's
Thank you,
like-
Michelle. I think there's an amplification of a lot of these issues, especially the workforce issues and health disparities post-COVID.
Oh, yeah. Supposed COVID residual.
Yeah,
Yeah.
just it amplified everything.
Yeah,
It's already.
It's not a resilient system.
Yeah, it's not resilience.
Yeah.
I think we also need to focus on, there's a lot of workforce challenges, but the issue is, what does that mean? And that means people can't get care.
It's just this snake eating its tail kind of situation.
Well, and I think I would write up there. I think what you're saying, Bruce, but this idea of long waits or, because when I get back to people about Canada is the long waits and I'm going, Have you tried to access there lately?
Yeah, we have
Any
long ways.
long ways.
Yes, exactly. People can't get the care they need.
Yeah, and then having to come back and in the ICU 3 days later, which is pretty sure my friends, yeah, just went through.
Yeah.
Hi, Cheryl.
At the same time that health plans are making profits, really high profits.
Yeah.
We're relying on state general funds to subsidize
Yeah.
health plans. So in term, I mean, I can speak to the behavioral health space. That the state general fund is having to pay for behavioral health care that health plans
They're supposed to be
refuse to
doing.
pay for.
We got parity in that.
Yeah, and it's not working now. Yeah.
I think that from a communications perspective too, to bring in that thread, there's also just so much, the jargon and the complexity means that people don't even know necessarily how to understand or advocate, how to advocate for themselves in the system.
Yeah. Creates a barrier, right?
Yeah.
Yeah.
I think along that line, I'll just call it Dr. Google. I think is kind of part of the current system.
Well, and now Dr.
You know,
YouTube.
everybody is, you know, immediately, somebody calls me and I'm going, well, let's just look that up.
Google it.
You know, Google it, we'll figure it out, but it adds some complexity to this mix and maybe some AI stuff that I don't quite understand. But is out there now.
Yeah, what's accessible. If you can't access this
Mhm,
system, but you
right.
have YouTube on your phone and you have Google on your phone and you have ChatGPT, like.
Exactly, yeah. I'm not sure if that's good, bad, or whatever, but it's there and it's part of the,
Or risk for disinformation,
yeah.
but also excessive information.
In terms of our current system, there's a structural and inherent injustice.
Structural
in
and
that
injustice.
We pay less to care for poor people and
Yeah.
older people. And we pay more to care for those who are well and well insured.
Right.
And that,
And in the words of Dr. Goldberg, wallet biopsies happen.
Say that again.
Wallet biopsies.
Yeah.
but our system pays less for certain populations and pays more for others. So unjust.
It's unjust.
And that forces behaviors that also create inequity.
Yes.
Also, under structural injustice, I would say the regional disparities in terms of access to care.
Thank you, coming from another rural area.
Yes, yes.
Preach.
And if the federal stuff that we're worrying about happens, it's gonna be worse.
Yes.
I would say one major root causes of all those problems is we are not a system. We are not a system. We have multiple systems, non-coordinated, competing with each other, and in the end, no one is accountable. And that's the root causes of all those problems.
Yeah, and competition means the scarcity mentality and there's one part against the other. Not meaning to. It's not. Yeah.
So technically, we don't have a system.
Competition for some things, but not for others.
Yes, that's a good segue to future state, like what would that system be?
People get the care they need.
Because we don't have a system, no one is accountable.
Lack of accountability.
There is no governance.
Right. Yeah.
The issue of governance in our current state is non-existent.
I guess I would add to the finance revenue pieces I've been listening to and whatever, is that we do have a high income tax system. We're highly, our income tax, relying on it makes things difficult as we try to figure out how to move forward, because people claim we already have. And the state revenue guy showed us, you know, that we do, you know, we have other things that we don't have, but it just, kind of as we try to think about the financing of this thing, and how do we get there? That kind of is in people's minds.
I'm gonna put this down in the hazards of the waters.
Okay, good, wherever, it just hit me that is
Yeah.
something I struggle with as we think about, how do we get from here to there? So,
Yeah.
because we just have a real interesting tax system.
Yeah,
Yeah.
is it so, yeah, I think it's like 80% of the state budget comes from individual income taxes, right? So.
Yeah.
And when you rank us with other states, our income tax is up. And so that in people's mind, we don't have really high income tax. How could you be thinking about more income tax?
Which I think there are ways to address that, but
Good.
it needs to be addressed, yeah.
Good content, yes, absolutely, we'll talk about that.
I think one thing that, oh, go ahead. Oh, I was just gonna say, I think that, and I know that you all have done a lot of work around this, around sort of the collective understanding or not collective understanding, or agreement by residents of the state of accountability and responsibility. So in other words, do they feel that they are accountable to provide healthcare for everyone in the state?
Oh,
Do they feel that they are accountable to provide healthcare for their family or just the people who live in their city? And there's not a shared understanding of that because some people, there's just a differing belief system in
yeah.
our society,
Underlying
not just
values,
Oregon,
yeah.
but in our society. And I think that is a mistake. Yes, I think that is part of maybe part of the challenge.
And to build on that, I think well, I shouldn't use the word we, there is a commonly represented, often expressed preference that isn't framed this way of being willing to pay for the downstream effects of lack of care because people do not want to pay for the upstream investment to make sure everyone has care.
Yes, that is an excellent.
I was gonna make a similar comment of something that's in the water, like what Mimi said, we do have a system that is based on, it's employer-based, it's a for-profit, it's a business model of healthcare that is deeply entrenched right now, and I think that's just in the water.
Yeah.
We don't believe in healthcare as a public good, as a society. We don't see it that way, we don't think of it in that way, we think of it as a private good that is operated by private companies on a for-profit basis, and that is so deeply entrenched, not only in Oregon, but across our country, that is gonna be incredibly difficult to navigate. It's changing the fundamental concept of how healthcare is delivered, so.
Speaking of jargon, the commodification of healthcare, yeah,
It's a commodity.
harmful, yeah, right.
This makes me think of Larry Wallach, who was, a big guru of all kinds of things and the Hatfield School of Government, et cetera. But Larry used to give a speech called The Wits and the Yo-Yos. And he said that underlying basic who we are in the United States is individualism. And so you get it that you're on your own. Those are the yo-yos. And the wits are, we're in it together. And so that's that constant battle between and how to get people beyond you're on your own, that bootstrap mentality kind of thing. And healthcare has kind of built itself on that you're on your own, unless you happen to be covered by this or that. And if you aren't, it's too bad. And we don't as a society have that in this together.
And
how
it's
to do
just
that.
getting more and more in that direction,
Yes.
this administration. I think that's in the water too.
Yes, okay.
Yeah,
More yo-yo than big.
Yeah.
accelerating yo-yos.
Right.
Actually, two decades ago, the industry come up with the euphemism of consumer-driven healthcare. That's a euphemism for you are on your own.
Yes.
Yes, yep.
Thank you for this content. Clearly, we're not gonna change everything in the current state, but I think it's so important that we know it's an environmental scan, right? We know what we're dealing with and what perhaps we can change and where there may be leverage points to bring people along.
Yeah.
And what we need to think about. Yeah. Anything else that's a burning,
When you said that, what is
yeah.
brought up to me is that I think younger people have a differing, they're more, we're in it together. When I talk to younger folks, they don't seem to have as much of as us older folks have this, you're on your own thing. I don't know, it just when they kind of resonate when you talk about this thing to them. Whereas when I talk to older folks, I'm having to kind of convince them and bring them along and to explain it to them. Whereas just some younger folks that I'm talking to kind of go, oh yeah, well, why not? And maybe they don't have as much to lose or they aren't as invested in whatever, but I do think some of it is differentiated by age.
Or they
Certainly
haven't heard of
generational.
systemic, trauma and betrayal yet.
Yeah,
Mm.
yeah.
We have a healthcare system that bankrupts people.
Yes.
And I think that's part of, I don't know quite how you say this, but. You know, at some point, these are all words, but you know, we have a system that basically causes people harm.
Yeah,
Yes.
yeah,
Uh,
yeah.
Bankrupts them. And the number one cause of person bankruptcy is healthcare.
Without necessarily improving health outcomes.
Exactly.
Yeah. I don't know if we should put this here, you could flip it for a future state for a more hopeful thing, but currently people are shackled in a way to their employer for healthcare benefits.
Yes.
Where in a future state,
Yeah.
there may be more freedom and more creativity and innovation.
Mhm.
Employer tether. Yeah.
Employer tether, I like that. I don't like it, but it's good.
Yeah.
Want to do a break? Or do you
Sure,
want
I'm
to
gonna feel okay.
Yeah, how are you?
All right. Yeah, let's take a quick break, 10 minutes. We'll turn the page. Okay, great job this morning. What I did was started with just a couple of grounding statements to get us thinking about the future state, but what we'd really like is to get some good meat around those bones. We should kind of have a general vision where we're going. We started with the mission, but with the current state in mind, I think we can get really specific and then we'll pull out the stepping stones and process steps that you all worked on and see if those elements will get us to that future state, okay?
Judy,
So,
can I-
yeah,
one thought back to here, just one little one, and it's kind of a big one, is that the voters in Oregon, not by a lot, but by a bit, voted in our constitution that they have a right to health care.
yeah.
So that is kind of in the current what's out there, and we don't often think about it or remind people or say, what does that mean?
That
But I think
fundamental premise is healthcare rights.
Yes, and
Or
we
is it
put it in the
evolution?
Constitution. And we're the only state, I think, that did that, has done that so far. So anyway, it's just kind of a thing that is there, and I think we need to kind of keep remembering and helping people know that
Be a
hey,
dolphin in the
we did
water.
this, yeah.
Thank you for pointing that out,
Yeah.
because that is a great example of a stepping stone. That's something that happened independent from our work. That
Yes,
exists there in the Oregon Constitution,
yeah, okay.
regardless of whether everything stops tomorrow.
Right,
There it
yeah.
is. Yeah, it's a stepping stone. Thank you. Yeah, we'll talk about that in
Good.
some detail.
Okay, great.
Appreciate it. So besides just saying, well, we want the opposite of that, because that would really help us clarify and articulate a vision. I did pull out some elements that I kept hearing this morning. So in our future state, we're thinking about a functional system that can be equitably, reliably accessed, doesn't cause harm, financial harm, perpetuate injustice, however we want to define harm. We want excellent health outcomes. I don't think that's too much to ask. Simplicity as much as possible in a complex systemic world. And that gets to the managed redundancy, cost control, and not profit driven. So what's in your mind's eye, thinking about everything we've talked about this morning, really specifically does this mean for the future state of our work? What does that look like? And you may need to transport yourself, 5 years, 10 years from today and look back, say, oh, we have his thing now. We were successful. We have the ongoing fireworks. We're the owls administering it. What do we have? What is it like being a resident of Oregon and needing to get healthcare?
Well, I'll start us off. I mean, we have the legislation that created this board that outlines a couple of key parts, which is that we would start with a public corporation and a trust in the treasury that would fund healthcare for the state. And that there would be some sort of regional entities that would then be part of the delivery of that system. The legislation states that the state is the only risk-bearing entity, so we're like bearing risk in one location. And it also specifies that institutional providers, which I think is interpreted as hospitals, have global budgets. And those get at some of the cost questions. And obviously, there are a lot of details left out. That's what the legislation asks us to come up with. We can discuss whether other options are still viable or on the table. But the legislation has kind of outlined those kinds of things. So in addition to those, what do we imagine that we're building?
Can you add the last one again? So I got public trust, public corporation delivered by regional entities, state bears risk, and what was the last one?
That institutional providers, which I think is interpreted as hospitals, have global
Global
budgets.
budgets.
Global budget, got it.
I think the task force also challenged us to seriously look at and improve the behavioral health system.
Yep.
The access to it, how it's paid for, how it's delivered, to really enhance that for Oregon residents.
One health plan instead of multiple.
I think what all this means is that people get care when they need it. Like increased access and health and improved health outcomes.
Yeah, access and outcomes for sure.
Yeah.
When and where, maybe?
Say again?
I was just adding on to Michelle's kind of when and where, so like.
Oh, when they get access and where they get access.
Yeah, I
Thank
mean, I'm thinking about
Yeah.
the old news and like.
Yeah.
Hopefully we can build back access that has dwindled.
And I think emphasizing that we'll have a system.
We'll have a system, like a
Because-
functional system.
Because it-
Yeah.
yeah, because I think as John always said, we don't have a system. And whenever I'm talking to people about the healthcare system, I always have to kind of put in
Yes.
quotes or something because we don't really have a system. We have a mess.
What makes it such?
What makes it such?
Mhm.
All those things.
No, what makes it a system?
What makes it a system? I think that we have accountability, that we have, I talk about it being under one tent. That all the parts of it are strategized and developed to work together. And but to do that, in my mind, is you've got to have accountability and an overarching kind of system that is accountability, I think.
In terms of the payer, or, because it's not gonna be one health system,
Yeah.
right?
Yeah, no, but it's the payer. I
Yeah.
think it really is, that we're really looking at the financial pieces that will make this
Yeah,
other
yeah,
stuff better,
yeah.
we believe. If you don't have multiple payers and multiple games able to be played. So that's what I,
But it's not just the payment that everybody
Mhm,
gets
mhm.
the same.
right, but so the benefits of the payment I'm putting all that. in. So, yeah, you're right.
And also back to our provider and provider burden and complexity conversation, it means that success is measured one way instead of 6 ways. It's
Yeah.
reported to one
Yeah.
entity instead of reported to 12
Yeah.
entities and.
Yeah.
A common set of metrics for, we know that
That
we're
we're
doing.
doing, yeah.
And we've already talked a little bit about a common benefit plan that's available to everybody with access to additional services through supplemental insurance. But that common benefit that everybody can access. And
Also, what makes the system, there are additional important principles. One of them is having a system that is accountable, not just for access, but also for quality and outcome.
To who?
To the
Sorry,
people.
how does that work? Like, yeah, what does accountability mean? Several people brought that up. What does that mean to be accountable? Like, who's accountable to who and how do we measure?
Who is managing the system? So we will have public corporation.
Uh-huh.
So the public corporation will be accountable. To
Like
ensure not
elected?
just access, but also the money. And that's something any country with universal healthcare, they have been doing that for decades. Also, having a system, a public system means we are not just healthcare system. We are also a subsystem of our health system, meaning we coordinate how to promote population health, how to enhance population health. Because the current non-system totally detached from population health.
And has disincentives actually.
Yeah.
To do population because people will jump around from this insurer to this insurer, and I've had them tell me that why should I invest in prevention and promotion? Because it's gonna go from X company that I'm in charge of over to this one over here, when the employer changes 2 years from now, because they can get, $1 cheaper premium.
Yeah. There's also transparency though, like, isn't that
Yes.
part of accountability? So like.
Yeah.
There is no transparency in the current fragmented landscape. And
About what?
about costs, about
Yeah.
decision
Yeah.
making,
Yeah.
about.
Yep.
The difference between what it costs the plan versus what the plan charges me. Yeah, there's very little transparency about anything.
Well, and even at the delivery end.
Yes.
Yeah. The fact that a hip replacement in one hospital costs
Exactly.
X and over here it costs Y. And
Can I put out-
no reason why
Yeah.
it is.
Yeah,
I'm sorry to interrupt you, yeah. Yeah, so you're talking about like a fee schedule, well, somebody mentioned that. And the only reason I'm picking on you is because I don't want anybody like transparency to my personal health information.
Yeah, no.
Right.
no.
yeah, but I think the other piece that's different here is we are paying, we're shifting where we're putting our, like, as people who access care. We are paying into an accountable system that is run ultimately by us.
People.
And instead of paying an involuntary tax to corporate profits. So shifting like how we're paying as individuals and as a society, like putting our money into something that's transparent and accountable
Yeah.
versus something that is just like a black box.
Similar to, well, we think maybe the Oregon legislature, right? We pay taxes and we hold our legislators accountable because they're elected. The way I'm hearing accountability, so, the people, the leaders could be removed if they're not doing a good job, if they're being, obfuscating. If we weren't doing a good job on the board, the governor could remove us, that kind of a thing. We're accountable people, so you can call on the heartstrings. Yeah, we want to be accountable, but you have to like beat the fire. How did that actually happen?
And the accountability is closely tied with governance.
Yes, yes.
Who make decision and who is accountable for the decision they make.
Yeah.
And then related to that, an important, both a challenge, but also an important principle is one of our mission point, the community ownership. So we, in the process, we need to make sure the Oregon residents can understand this is not something out there. This is our system.
Yeah.
This is the Oregon residence system. That's the nature of community ownership. But that's not just in words, but it has to be in practice, meaning how can the system, once it's in place, how can it be responsive?
Yeah.
Be responsive to the community, to the people, the residents' needs. The needs can change, the preference can change, and the system has to be responsive to the people.
The science changes too, right?
Yeah.
Double whammy.
So this is fantastic, and this is exactly the conversation that Judy and I were hoping to have, and I want to move us from sort of generic values and concepts to specific things that we need to do over the next year. That's kind of the work that needs to happen in the next year. So as these things come up, I want us to think about, some of these are unresolved issues. We haven't figured out exactly how this would happen. And when these kind of questions come up, we need to think about which questions belong at the board level. What are the things that we need to discuss and resolve as a board regarding the structure of this plan? What things need to stay in the committee level that are currently in the committee level, and what things we need to ask our consultants to step in, do some research and some reporting back to us. So we've already
And
come up with.
what things do we not need?
Yeah. Exactly. What things can we do? Some other, right, exactly.
For at least the time being.
Right, so already we have a list of some structural pieces of what the plan will look like, and we've mentioned accountability and transparency. And just like to pause a second on those three things and just talk about, like, we need to do some discussions in our next couple of board meetings about exactly what this is gonna look like. So for instance, with the structure, there's a lot of vagueness, I'll say, about these regional entities. And so we know that there's a public trust, we know there's a public corporation, that's kind of set. What are these regional entities? How do they function? What is their role? The legislation says that they don't bear risk. We need to consider what that means. And so Judy's already putting it there, but those are some questions that the board needs to kind of wrestle with in the next couple of months to kind of sort that out and move from this generic, sort of value statements to really how that would play out. I want to go back to accountability a little bit, and sort of work that through a little bit more. You mentioned that the public corporation would be accountable. What would that mean? Like I wrote down, does that mean that quality and cost data are publicly available? So that we know how much we're spending every year and we know the quality outcomes that we're getting? Is that regional? So let's kind of drill down a little bit and figure out what does it mean to be accountable? What things need to happen there? So we need to have an accountability plan for the public corporation, right? That's a board level discussion that we need to resolve.
I can share with you one example from Taiwan. With this year, they celebrate 30th anniversary of universal healthcare. So when they set up the universal healthcare in 1995, they have a government agency currently called, even through evolution, the currently called the National Health Insurance Administration. That's under the Ministry of Health. But this National Health Insurance Administrations, they have 6 regional offices that take care of regional business. Because with a population of 23.4 million, that's almost 6 times so low. They need that. And this agency also accountable to our parliament. So the parliament overseeing how they're doing. And of course, the way people respond to their need or unmet need is through the legislatures. So the legislatures will put pressure on the government agency. So the National Health Insurance Administration is equivalent of our public corporations. We can mention that role. And of course, the legislature will be overseeing that, their operations. So they are accountable to the public indirectly through the legislature. Or we can design a different mechanism that we can have. In Taiwan, they also have a similar with the governance board that gives policy and directive to the agency. But the agency is responsible, accountable to the parliament.
So what I captured that, Chenwei, thank you, and I also added a question for the consultant task, and you guys can say I'm wrong and I'll cross it off, but I'm wondering if they can give us, like, this is how public corporations have been publicly accountable in the past. They're elected, they're whatever it is, whatever those models are, both nationally and internationally, and we can look at Taiwan, but there may be some other models too. What does that really look like? Are those people appointed? Are they hired? How are they kept accountable? And what happens when it goes wrong? What can we learn from that? So I think that's a good consultant question. You can decide which ones. Maybe it's kind of like HMA's whispering in the background. We've already done it. So.
Is there a single set of quality metrics for the whole state? Can they be regionally adapted? I'm not, and we don't have to answer that right now, but where does that question belong? Does it belong at the board level? Does it belong at the committee level? Does it belong with our consultants? We need to sort of start like working through some of these questions. I mean, I think the committees can do a little bit of work on the,
Like plan design for the metrics one?
yeah, that's
Yeah.
part of the plan designs.
Mm-hmm.
Charge is quality metrics and what they should look like, if they should be regionally adaptable, or if there's just a single set for the state. Yeah, Amy, you had something?
Yeah, and thinking about the metrics and thinking about disparities, during the break, for example, I was talking to Kim about realty and, you know, like how many years in are we, and it hasn't really ever been fully implemented, and like I'm on SOCAC and we're asking for data on intersectionality, they can't give it.
You might need to explain what all that is.
It's realty.
Realty is, the, rate, I'm gonna look at Kim,
Race,
race ethnicity,
Language.
is the A language, or H, language and disability?
The A is and.
It's a new way. of
Oh, the A is
collecting data.
and, okay, thank
It's
you.
it's a new way of collecting data.
We should look at both.
Yeah.
That accounts for all of those factors, those
Yes.
characteristics.
Yeah, so just thinking about like our aspirational goals to get to accountability, and then thinking about like our current state and I don't know, just how do we get from here to there?
Well, speaking of data, what about IT system? Where does that live? Just single IT system, like it's for data and financial, you're not gonna get it for.
All right, so that's currently assigned to the operations committee. Is that where it belongs? Do we need to have some discussions at the board level about that? Do we need our consultants to do some work on that?
Is that something we know yet, Bruce? Our next month, we're gonna talk to them, to Millman, about what they offer.
Regarding the IT system, once we have this system, every resident eligible will have the Orange Universal Health Plan card. And that card can have an encrypted chips with the identity. And then every provider should have a state issues encrypted reading machine, so they can access through that reading machine. They have access to cloud information. The cloud information has different sector. One is regarding payment and claim. So the provider can send claim directly through cloud once they see a patient. But also patient information and record, including diagnostic, imaging and prescription drug, etc. So these are integrated cloud system, a big IT system we need to build. And in Taiwan's case, their healthcare cloud is not just passive providing information, it's also active. For example, if a patient just got a CT scan 2 days ago and this hospital try to get another CT, it will warn the hospital. Likewise, for the pharmaceutical prescriptions, it's active. But if the patient see other providers and have other prescriptions, and now this physician try to prescribe some, either is redundant, it will warn them, or interaction. So it's a very active smart system.
That's like a consultant thing too, is to explore other models of
Yeah.
integrated data systems. Yeah.
Yeah, Bruce, it's our hand.
Yeah, I'm just wondering whether we're getting a little bit too granular.
I was too.
In some of this. I mean, obviously, I mean, Joel, you're right, we need an information system, but I think, you know, some of the bigger issues are, you know, what could and would an IT system cost, and where would the funding come from? Whether it'll have every claim in it, or, I mean, I think becomes sort of something a little further down the road.
Yeah.
But not gonna know, though, it's kind of, you know, unless you know what you want, you're not gonna know how much it costs.
But it's not too further down the road, because once this plan is in operation from day one, we will need that.
Oh, I'm with you, I'm just,
Yeah. Today.
yeah,
I'm embracing the process, it's all good, we'll prioritize later.
The transparency was
Yes.
brought up too. What does it mean to have a transparent system? Are we publishing quality and cost data regionally, statewide? Is that something you should be able to access, how much things cost before you, well, it wouldn't, but doesn't apply, I guess, if it's part of the covered benefits,
Right.
but, you know, how will systems know how they're doing on quality? How do we know how much things cost? How do we know regions are on track to meet cost targets?
But on a higher level of transparency, it's about who make what decision and how was the budget spent.
And having spent 5 years working on open notes, transparency from the patient perspective.
Yeah.
In terms of what are people saying, if I'm denied why, you know, all the things.
Yeah. As we go through the work plan, I think more things will come up, but just kind of trying to outline a little bit of what, but I don't know if anyone else has thoughts on what the future state should look like and, or if we should dig into sort of.
This is great. We'll keep going back. I've got all the colors. Yeah, okay.
Amazing.
You wanna move to
Why
the,
is one with your fingers there?
stepping stones? Okay. So I've tried to catalog all the stepping stones. What I'm gonna do is call it out, and if it's yours, claim it and explain to the group what it is, and I'm just gonna grab it. Okay, so there's process steps. Those are things that need to happen to get us towards the future. And there's definitely stepping stones, which can get us towards the future, but they can even stand alone. And so, if Mary Lou's example of healthcare as a right being a stepping stone, it makes you think that, oh, this process step is a stone, or the other way around, that's totally fine, we can change it. Let's start with. I have non-emergent medical transport and emergent medical transport system reform. I think that was plan design. Helen, can you explain what that means and why it's stone?
Well, I would just say that currently non-emergency medical transportation is one of the covered benefits if you're eligible for Oregon Health Plan, and it's fantastic and very necessary. But we also have this emergency medical transportation system, which is ambulances and various air transport mechanisms when people need to move from one place to another. It's incredibly expensive and really difficult to access. It functions as a separate part of the health system, and how people get transported from skilled nursing facilities to the hospital, from home to clinic, from home to the emergency room is a complicated process, and it's really expensive and really inefficient. And so just taking a look at the whole transportation system, how the transportation system would function, I think it's a good example of a stepping stone, because if we just looked at that and kind of came up with some ideas and systems around that, that would be necessary in a universal plan to have a coordinated system for transportation. But even without any system like that, it would be worth looking at how we would do that.
Would secure transport be included in that?
What do you mean by that? I don't know.
That's transport from a hospital, you know, the state hospital, from jail, for someone who's involuntary.
Oh, yeah, absolutely, absolutely.
That's the problem.
Yeah, exactly. Yeah, like the whole, like anything involving the transport with the healthcare system. Yeah.
Can I ask a process question? I think this is really helpful and clarifying, and I guess one question that I have is when we're writing the first edition of the Universal Health Plan Governance Playbook, do we have to have answers to all of these things, or do we have like, here is the starting plan and the elements of it, and here's phase 2. And here's what we recommend a future group dig into and figure out, because I want to make sure that we can get to something that is a playbook
I'll go down all the rabbit holes, right?
and account for these other things that will need to be figured out.
Exactly.
I think that's really key, because on October 1, 2026, it's not as if you sit and you wait.
Right.
There's gotta be work that, here's what needs to get accomplished by September 30th. And here's what happens over Q1, 2026 and Q2. I'm in total agreement.
Exactly. So you could think of stepping stones as sort of part of a transition plan. That these would be kind of components that would happen in the interim as we're working towards sort of the bigger system change. But yes, we don't have to have all of this worked out. We can say, we think there needs to be, you know, a group that figures out the transportation thing, you know, like, so, but on the extent of what we did with
Right.
that, right?
Okay,
Yeah,
that's
so-
my question.
so-
Where does that
so-
capacity
Yeah,
go?
just,
Yeah.
no, yeah, discrete bodies of work that we don't necessarily do as a body, but we think could be done, should be done as part of a transition to a more functional system.
Okay, thanks.
For sure. So I put over there, the elements of the playbook, things that are necessary, critical, things nice to have and nope. Just not gonna get to it. Okay. Regulate health plan reserves. Say you sure?
I may have put something about reserves. That was a
Does it
while.
ring a bell? Do you want to talk about it at
I
all?
mean, we've certainly talked about it in finance and revenue.
So like a policy thing.
We don't have any proposals yet,
That's
but
okay.
this is something that we need to do.
Yeah, yeah, if you could regulate health plan reserves and what happens then, that would be.
And not only the reserve, this has come up often, it's not just establishing our own reserves for the health
Mhm.
plan, but it's what do we do with all the reserves of the.
Those
current
guys have.
Yes.
Yeah,
Yeah.
yeah, I thought I
That's-
interpreted that.
The issue is
Yeah.
how do we get hold of those
Right.
to help us build this?
Reform behavioral health codes and payment regulations. That sounds like plan design. Yeah.
Yeah, that came from plan design. Right, our understanding from the small group work that happened in our committee was that, that how behavioral health is paid for. How, and the mechanics of getting it paid for in terms of data collection and processing is really complicated and burdensome. And the workforce issues as well in terms of how providers are paid and how much they're paid. Is a major inhibitor for expanding access.
Yeah, and administrative burden contributes to their accidents too.
Yeah.
Not work.
Right, so removing the administrative burden.
Yep.
And reforming how, behavioral health is delivered for in terms of, So so that if we did that in and of itself, that would be lovely.
So this is a great example of maybe we don't have to do this work. There's ongoing work right now over there. Trying to help fix this.
Yeah.
I wonder if anyone is paying attention to that, if we can nudge them to fix it in a direction that supports us. Not the opposite, right? Cool. All right. Style guide. Oh, sorry.
Just a lot of moving parts.
There are all in chess, right?
So,
This style guide, do it, our own style guide is the OHA style guide.
It's our own.
How often do we revise it?
Tell me more about that.
How do you get a style guide?
So we do a scan of existing style guides that are relevant to our work. We fill in with the help of our consultants terms that are specific to our work, and that way we all communicate without jargon in plain language intentionally. We do no harm, and we increase understanding and hopefully buy-in.
Yeah.
Consistently. So like if I go and speak to a group outside of, outside of this board. And Chunwei goes and speaks to a group, we use the same language, everyone's hearing the same
Yeah,
message.
it's gonna report the same way. Yeah. Limit out-of-pocket healthcare costs to 10% of income. I like that one.
That's kind of plan design as sort of a stepping stone.
Yep.
That one of the things that we could do was try to support households and families with limiting their yearly out-of-pocket costs, if that's feasible. It will of course have other downstream effects if we did that.
Yeah.
In terms of premiums and stuff like that, but the idea was that households shouldn't pay more than 10% of their total yearly income on healthcare costs.
So if it's a stepping stone, is that a policy
Yeah.
fix? Yeah. Yeah, because we can certainly bake it in.
I love how that centers people instead of systems. We have the current cost growth target work that is about controlling costs for the system, but it has done nothing. It has actually increased costs for individuals.
Yes.
So I really like the way that that flips the focus.
And that's exactly my concern about the fix for this. The fix I'm going right now is like, we'll just throw more money at it. The broken system. Single state formulary or state prescription. I love this one. Helen, if you didn't write this one, I was gonna write it, but let's talk about that.
You do.
RX, is that what it is? There is a state formulary.
Oh,
Nobody
yes.
uses
All right.
RA.
Yeah.
Nobody uses it. Clinicians in the room, we know we go through machinations and workarounds to try to get payment for medications for our patients. But there's a single state formulary that was compulsory or incentivized for hospitals and providers to use. Would be super helpful. Maybe incentivized.
Nobody's keen on regulatory.
Say again?
I said nobody's keen on regulatory.
True. Yeah, everyone likes carrot, right?
Yeah, right.
Everyone likes carrot, not a stick.
I have a
Yes, sir.
comment and question related to that issues. This is related to procurement of
Mhm.
prescription drugs.
Mhm.
Because once we have this in place, we will be the big payer for all prescription drugs. And we are state not a country, but most countries which is much out here.
Mhm.
The government negotiate
Mhm.
on behalf of the whole population
Yeah.
to get a discount on the prescription drug. So we may want to present that mechanism, procurement for prescription drug and price negotiation.
Monopsony power, my economic friend. Yes, monopsony. Cool. Okay. Global budgets for hospitals?
That was listed as already in the,
Got it.
yeah,
Who's responsible? for
plan design, yeah.
Plan design, okay.
Yeah, so that it's in the legislation but that is something that.
It's still a stepping stone, though.
Yeah, it's still a
a
stepping stone because-
standalone. If that were, like, that could happen before
Yeah.
other things. And I think that it would be exceptionally useful in terms of like the rural hospital closures that we've been talking about.
Yes, yes.
So they
Also,
could-
there's a detail to be hashed out, the global budget for hospital, we're talking about the one budget for all hospital, or one budget for each hospital, or one budget for each region's hospital. There are many varieties. of-
There are.
and,
Who answers that question? Or helps get us the information? Is that a board question? Might be in the weeds too much today.
Yeah,
What does
that's
global
a-
look like?
Right.
A consultant.
In Taiwan's global budget, they have a global budget for all hospitals. But then that total budget for all hospitals are divided by region. Taiwan has a 6 region, so they're subdivided by each region.
And it's different in each region.
But under the same budget, the same budget is carved out for 6
Right,
regions.
there's much for hospitals, but then, let's look it up.
Who wrote
Yeah, it's a
local-
zero
hospital systems that are across regions.
It's interesting, that's a zero sum game, right?
Yes.
If you have a sector global budget for all hospitals, then if one hospital is more than others, so they would have to negotiate among each other, or how does that work? Do they?
Yes, the hospital association negotiate with each other.
That's a really good deal. Local health engagement councils, that can. Yes. What does that look like? What are those? And why, are they different than the CCO, community?
The CACs. I mean, we were thinking of it as a kind of replacement term for the citizen jury concept,
Uh-huh.
but at a regional level. I don't know that we've thought much beyond that, looking at Michelle.
Yeah.
Great idea. It's like the CCO model, right?
Well, kind of, it more relates to community, it's more about governance and
Yeah, the
community
governance.
ownership.
Okay.
What will they do?
They will help determine priorities and make changes to the plan and what's covered over time, or the state formulary and what's covered to align the plan with changing population needs over time. So they could be related to those regional entities if those needs are different by region.
Does that happen before or after there's a plan is in place?
Building the plans.
Exactly.
Good question.
Public,
Because who do you give that input
To.
to at that point?
Yeah. Yeah, whoever's doing the interim work.
I'm gonna put that as your committee ongoing work, okay?
public option for long-term care.
Yeah, that came up in plan design. We had a small group thinking about long-term care and we did some, they did some background work on what's happening in Washington right now.
Yeah.
With publicly funded long-term care insurance. Because so few people have long-term care insurance and we had a discussion that it would not be part of our basic benefit package. And so what would be an option for folks? How would that work? You know, how could you buy into long-term care insurance?
I still think we need to be specific because long-term care is also used for how disabled people are able to survive and be in community versus, nursing homes and students.
Right.
So
Right.
it's the same word used for both, so we need to be clear on what we're talking about and not.
Yeah.
Glad you guys are working on a style guide, because we use a lot of words interchangeably, like provider, like payer, like, oh, yeah, that's a good one too. Okay,
I think
reference,
it's covers both. I think it's.
reference pricing, did we talk about that yet? Reference pricing, what is that about?
So uniform fee schedule.
Yeah.
Basically for, I mean, because we talked about this with, if, there's gonna be a single set of benefits and a single payer, then there's a uniform fee schedule, like. Right now, how much it costs to get your knee replaced depends on who's paying, right, and where it happens, if it happens in an ambulatory care center or in a hospital. And whether you have insurance, commercial insurance or employer-based insurance or Medicaid or Medicare, there's a different fee depending on.
A normal person, is that?
Yes.
Right, like a single fee schedule.
Yeah.
that
That's
everybody-
different from reference.
Right, and so reference pricing would base the fee schedule like on like Medicare, like we pay. So I think the task force came up with like 126% of Medicare pricing would be what things would be paid for across the board, right? So.
Well, that was the amalgamation
Yeah.
of all the payers.
Right,
It wasn't about setting a fee schedule. I mean,
right. So if you redistributed the money, what would that roughly work out? Right.
Can I make a quick comment, backtrack to the
Mhm.
long-term
that had more
care?
to do with paying
Yeah.
than with.
The long-term care may have an issue that requires the board to make final decision,
Okay,
because the standard inpatient care is covered in our universal health care. So what is the boundary? We need to define that. What is long-term care?
Mhm.
That's not in the standard
Yeah.
inpatient care. So I think that eventually we'll need the board to decide.
Yeah, and can I just use an example that I feel like I bring it up, but people aren't clear because. So for disabled children, having access to paid support workers in their homes keeps them from being institutionalized in behavioral health or mental health settings like it. So. That's a very different conversation, so I just want to make sure when we're lumping everything under the one, there need to be different conversations.
Maybe that would be your style guide, but like long-term supports and services is usually used. as
Yeah,
well.
yes.
But anyway, that's a
Yeah.
style guide thing, sorry.
Yeah. PCPCH investments,
We just say yes.
What did you say?
patient-centered primary care home investments. The Oregon particular flavor for the primary care home that our esteemed governor Kitzhaber used as the engine to drive the CCM. Thank you. Double down on the investments. Oh, it's just getting good. Okay.
Excuse me, could we add
Yes.
CCBHCs to that too?
CBHC, yes,
CCBH.
absolutely.
It's like a behavioral.
Yes.
Because some people, they would consider the behavioral health entity their primary care.
Yes, absolutely. Reverse integration, all those things, and it's just related to that. Sure.
We call it bi-directional integration.
There you go. Bi-directional integration. Okay, if stepping stones come to mind, stop me, I'll put them on there, but let's talk a little bit about the process steps that the committees are working on, and bear with me, we're on the fast track to lunch, so we'll get
Can I-
there.
Before you go
Yes.
on, Judy, so one of the things that, I know that this is being brought up, but to me, it seems like this is a question about whether it's board or it's committee, is payment model, which of course is huge, and if it is going to be something like, well, we're just, have a standardized fee schedule and it's back to fee for service.
Calling the question, is it fee for service? Yeah, I like
And
it.
so I think that that is a very, very big thing, which,
Absolutely.
will, one hopes, help with cost containment and other things, but I think that deciding where you all are going to decide, or even who's going to evaluate that I think it lives in plan, in plan design, rate and expenditures, but that is a very, very, very big, that's a big topic.
Or does it live at the board level? I mean.
Exactly, that's what I'm
Plan
saying.
design
Like, right
means
now,
like-
I think if that's where it's.
Payment model.
Well, and also, is there, I don't know where this is at with the plan design committee, but are there key questions like this one that you want us to pose when we meet with healthcare providers for engagement? And get some feedback, like here's how people, like here's how it would work
Yes.
this way, here's how it would work that way. What are your thoughts? I don't know that, like, that's a question.
You bring up a really good point, and I think that's part two. Can we sit down and clean this up and get you a list, and we can prioritize it and be like, okay, for the board to address this question, we need to farm it out and ask, what do folks think? Or we need to be like, no, the economic data shows that this model is what is gonna be sustainable. Or whatever it is. Yeah. I think it's phase two.
Perfect.
Yeah. Good work, everybody. Anything else to add before we keep going?
Okay. Provider payment strategy is related in one of those. That's good. It'll just pop it there. You're already talking. Eligibility and addressing long-term support services. Eligibility, who's working on? Something like plan design. Eligibility, either questions of eligibility, or you're talking about attribution as well. You remember, Ellen?
Sorry, so I can take over from that. I apologize, I'm not familiar with that.
That's okay.
So it's eligibility of what?
Eligibility and addressing long-term support services, I think maybe were two things.
I don't have that on my.
Okay. I'll just stick it here, and then if somebody remembers, we'll.
Benefit package.
Plan design. Do you need any questions answered from the board to continue along your work? Establishing the core benefit package? Are you still working on PEB? Or is it PEB plus?
Yeah, Pet Plus and then the behavioral.
Yeah.
Yeah. Yeah.
Appropriate use and quality metrics.
So this is great, it's intentional, because many of the process steps, if they're focused on or refined just a little bit, become those stepping stones, right? So appropriate use and quality metrics has to do with like choosing wisely campaign and judicious use of resources, and then a single quality metric. So how are we measuring whether or not we're succeeding?
I have used Artemis Consulting to engage key stakeholders on draft.
Do you need any clarification from the board? Or are you working with?
I think just any updates on timeline. Yeah, I think every board meeting, we just check in and say like, what's the updated time horizon so that we can plan and let our excellent consultants know.
I have you guys a strategic frame and core plain language talking points replacing jargon. Awesome. Cost calculator.
I think we've mentioned that.
I mentioned that a few times.
Consultants.
I will offer that, when we met with Echo Northwest, and got, sort of did a baseline ground setting with them, there are revenue consultants. They said it would be easy to come up. And easy to come up with a cost calculator, and they were happy to add that to their scope of work. So that's something that came up and.
Doesn't sound easy to me.
They offered that and, easy.
Seems like it would be easy to make, but the question would be, how confident are we in the inputs?
Yes.
Well, this cost calculation of what?
So the idea would be, you put in how you currently get healthcare. I currently am employed by, so, and this is how much I pay. What would happen to me in the new system? And it would, and then spit out, here's how that would work for you. You'd have the same benefits, or you'd lose this benefit, or you'd have access to this, right? So it would, you would say what you currently do to access healthcare, and then it would tell you how you would fare in the new system. So, right, exactly, so, sorry,
Yeah.
of course, yeah, you're right, so it would say, okay, you would no longer have to have you would no longer have a $3,000 deductible, but you'd have this income tax, which would be this percentage of your income, right? So it would give people that kind of data so that they would know what
People are really asking for that.
exactly.
And I think it was for not just the individual, but
For the
the
household.
employer.
Employer too.
Yeah.
Can I also just flag a comms consult request for that? Because I think the one challenge that I'm thinking about is that I don't know that people understand what they're paying now.
Yeah.
Right.
And so that could look, without that context,
Very
that
good
was
point.
really scary.
Yeah.
Yes.
And actually undermine, like do harm,
Yeah,
so.
and would you be looking at individual or household, so like, for example, like I buy through the exchange, I would put this. And try to get like, how do you know, kind of,
Yeah,
each person in the family might have different.
I don't know, not
That's why
expertise.
I don't know if they understand.
Yeah, no, they do, like, that's their expertise, they said they've done it before with other models, because they worked on this kind of project before, and they said they have experience making cost calculators, and they.
For individuals and businesses too, right? I mean, I'm sure Nike knows that this year they pay $27,000 per employee to cover a family of 4. That's a car every year, cheap car. Yeah, maybe not anymore.
Not anymore, but.
Yeah, sorry. Okay, over 2 years, you might get a car. It's way too expensive.
A car on Craigslist.
Okay. Obtain a universal waiver. Obtain a universal waiver, Medicare, Medicaid. Do you have anything to say about that, Bruce? 'Cause Operations is looking at.
I guess I would personally take the word waiver out, and I would talk about how you get permissions to do what we want to do.
Seamless commission.
Yeah,
Give us some money.
Authorization.
Like feds give.
yeah, because, I mean, waiver is a technical term.
Okay, yeah. Talk to the governor about that, he might have something. Okay. Establish the legal parameters for public corporation, I put this one here, we're working on that in operations, and that's a consultant question. Or policy analyst going on.
Is that covered in the first bullet, under the consultant or other public corporation?
Maybe this is like, what other states or other systems have public corporations and how are they held accountable? This is really the legal parameters that define how we function, procurement, what does the structure look like?
Just to be clear, I'm talking about what needs to get done now versus later. I'm not so certain that's a immediate task. That's something, all the things in the middle aren't necessarily things that are gonna get done over the next year.
Right, fair.
So I think how we want to wind up the discussion when we're done with this, I don't mean to say that we're doing this now, but then we're gonna look at this and set a priority. Set some priorities. What are the things that need to happen in the next 6 months to a year? What do we need to be focusing on now? We just kind of wanted to lay out the
And what are the
landscape
Right.
and then say, okay, these couple things seem to be like the first things we need to tackle as a board. These are the things we need to assign to our committees and to our consultants to help us work out, so that we can get where we need to be.
And then we can look at what are the dependencies, because like our committee is dependent on all the other ones.
There are dependencies for sure. Yeah, this is kind of like a work breakdown structure in project management. You just like put everything on the wall and then you organize it based on priorities, timeline, dependencies. Mhm. Yeah, okay. So this is about a universal waiver buy-in option for Medicaid. Might have been plan design. Was there anyone's homework I didn't get to or thoughts that come up as we do this work? Because I think that's everything I farmed from what you guys sent.
I'm wondering if somewhere, maybe a banner across is cost containment, and I'm trying to think about how to highlight and,
For sure.
because that's, crucial to all of this, if the plan is to expand healthcare access and better healthcare to a larger number of people, that does need to.
Is it a cost containment plan or process or?
Well, I think that is
Cost containment strategy.
strategy, I think is probably a better word, because I think that, so just as in like healthcare quality is almost
Yeah.
sort of like a strategy, I think like
For sure.
containment, how that is
And I think some of that,
crucial part of all of this work.
I think some of that really, this consultants looking beyond things that we're doing in the United States, because I think we're, we have these kind of preconceived ideas of what we have to do. And some of it hasn't really proven out in other places, that, oh, we've got to help restrain utilization. Well, other places that don't really have all this kind of restrictions don't have really more utilization than we do. So that's why I think sometimes we put these things in place to keep it down, and when I'm not sure, and I'd really like to know in other, countries, all these countries that have it, kind of how are they doing it and how is it working? We have a lot of restrictions at first. or something.
Yeah, we transition where you can, went to that.
We heard from our healthcare cost growth target program that, do we need a target or a limit on how much our healthcare costs can grow each year? And if so, how much should that be? If we said a certain, how much do we want it to grow, and would we, cap it at a certain limit of growth? How does that work?
I think that plays into something that's not up there also, which is along with cost containment, it's how is care delivered?
How is care?
I mean, this assumes that, we've all said we have an incredibly complex system. It's terrible to get care and nobody likes it. And we're assuming, well, if we just create a better payment system, that's all gonna get, that's gonna magically get better. We're all gonna be able to get appointments right away. It's a system where it's gonna be focused on primary care and public health, and we're gonna be able to get the behavioral health care we need. I'm not so certain any of these things get us there. They get us a lot about financing, which is great, but we don't want to just finance a broken system. We want to create a care model and a delivery of care that's very different from how we're focused today. And I don't know how to articulate that succinctly, and don't know where that is up there.
Right, how does primary care work? Like, is there a certain amount of primary care per region, or like, how do you get a primary care provider? Do you need a referral to specialists? Do specialists like work within the regions that they are? Do they work statewide? How do we manage utilization? Like, how does all of that happen? Like, and how do we increase the workforce? Because we're short primary care now, and so what would we do to increase the primary care workforce for sure, and then ensure that our specialists don't bolt? Because if there's gonna be a pain point in the system, it's probably in the specialist system where they'll probably be an effect on their compensation, right? And so there's gonna be incentives for specialists to leave, right? And so how do we ensure that specialists that all provider groups like that, we have enough primary care providers, that we have enough hospitals, that we have the specialists that we need, and that those are all sustainable in this way. And I'm really curious in this kind of system, how you find a primary care provider, because currently, most people, I think, go through their plan, right? You start at your health plan and you find any available provider there. So how does primary care work? How do you get a primary care provider? How does primary care attribution work? Because that's really key for quality outcomes. Yeah, and how do you build the workforce? Those are really good questions.
And how does the patient or consumers have more, not less choice? Like, in our current system, like, is it gonna further constrain the choice piece about who they see, where they get referred?
And related to that issue is the board may also need to decide whether we want to have every resident free access or they need the primary care as a gauge.
Right, I put that here, like, put the, how is care delivery improved? Is it built on the CCPHC model? Is it, medical home neighborhoods, which is expanding specialty care? Is that the right idea? And then how do you get into that? Like, everything that's coming to my mind, I'm thinking, well, that's not equitable. That's, they pay taxes, well, I don't know. Yeah.
How do we, I mean, some of the things. I mean, I did consulting work on the PCUPCH years ago, but then as I've gotten more involved in disability advocacy and justice, some of those systems are quite paternalistic. And don't offer the choice piece. So how do we, if we're looking at the model, really look at it, you know, from the different perspectives?
Yeah, I think those are really interesting discussions. They're way down in the weeds and thinking about things like, oh yeah, like our motor voter policy where you registered everyone to vote when they got their ID or their driver's license isn't like, that was a process to get a bunch of people registered to vote. This could be a process for people in the healthcare system, but you're gonna miss a lot. You're gonna miss people. Yes.
This is probably a post 2026 issue, or maybe parking lot, whatever you want to call it. And I think we need to explore merging our efforts with Washington. Like, if we're on the list.
Best Coast,
Yes.
yes, Best Coast argument.
We did just meet with the California team and we're gonna connect California and Washington and us all together, so.
I've been, looking for that, and sort of my comment on that is, we're still struggling to build a bridge between, or like a physical bridge between, or like that's been many years.
That is true.
Can't seem to make that happen, so making a sort of
Yeah.
joint health.
Well, two different things. One is we should be talking to each other in terms of exchanging information
Yeah.
and knowledge.
Yeah.
In terms of building,
A West
a
Coast.
bi or a tri-state plan, I would say, I've been down that road with trying to do things and it becomes really.
Yeah, that's what I mean.
complicated.
People learn from each other, as part of
Right.
like CMS.
Yeah.
But we have been talking to both. We have regular meetings with California, and Jenny was attending the Washington, I forget what they're called, Washington Commission. There's a commission, yeah. So we had definitely sort of been talking with them and exchanging information, but yeah, we should keep doing that.
I'll fix this and give us, I like a sustainability garden rather than parking lot. I hate getting just put to the parking lot. But what you give us is a little seed and something's gonna come of it. I don't know if it's gonna grow today, but yeah, it'll definitely do that.
But I do think exchanging information, keeping each other posted is something.
Yeah.
It's
It's kind of getting
Yeah.
rebooted.
Cross topic for
Yes.
sure. It's great work, and thank you for those of you who are very like not into the visual stuff for bearing with me. And we'll do some brush up before the afternoon session.
So one quick thing that is missing that is not within our scope or resources or timeline, but will need to happen for this future state
Yeah,
is a developing and launching a statewide plain language communications campaign to help people
Learn how to use it.
understand what this is, what it means for them and how to
Yes.
access it.
yeah.
It's like part of the change management process that's public facing. Because if we just do all of these changes and do no intentional broad communications campaign, then I think,
More chaos.
yeah,
Yeah.
well, also somebody else will frame this for us.
Yes.
And I don't know if we want to keep it where it is, but I'm noticing the thing that we had put in a future phase also was the local health engagement councils, but we have it here as an interim process.
Oh, this is stepping stone. Oh,
Stepping stone, but yeah, but
Solid.
in ours, we had it in like a future along with that, but it doesn't.
perfect. Yeah, all those stepping stones will be in our future.
Okay.
Is the intention. For sure.
Is there a dental stepping stone?
There's not.
Could we make one maybe?
Oh, yeah, those guys.
Right,
Well,
well,
that's
that's part
it.
of, they're in part of the.
Oral health, yeah.
How would you say that? Is it
Are
like-
they? That is my
Oh,
question.
oh,
Are
question,
they?
are they?
Right.
Are they? No.
Yes,
The dental listed.
Part of this
Listed as,
plan.
It's planned then.
Right, that was what I
Gotcha.
thought, however, just as
We have.
behavioral health system and
Yeah.
dental payment and dental
Right.
healthcare access.
Yes,
I think
yes.
that might be
Yes, yeah.
And there's.
oral health. Yes, thank you for.
There's definitely more of a divide when you're looking at current Medicaid.
Yes.
and Private.
100%.
Because it's like,
No, there is.
And look at numbers of providers and.
Mhm.
yeah.
Because-
System.
because it also knows fields that they might be.
Oh, yes. No, I know. If they get in.
Yes.
That's a
Part of
huge
their
one.
healthcare.
The consideration of ancillary providers, physical therapy, occupational therapy, speech, all of those kind of support services that currently bill through plans or groups like, that in the weeds, but has to be.
And I think Kurt's looking at active.
Acupuncture, chiropractic, yeah, anybody that's licensed.
Complimentary.
Good, good.
Yes.
Good job. Oh, sure. Good job.
It's big.
Yeah, we learned this statewide communication campaign. Remember when we expanded Medicaid? And in my region, so there's lots of farmers who are self-employed, and all of a sudden they were covered in the health plan. They had no idea how to access care. They all showed up in the ER because minor things. They're like, well, this is the only thing when you drive by the hospital, it says care, right? We didn't have urgent care, and so we needed the process to help navigate through that system. Help them realize what their benefits were that they weren't using.
Yeah.
And that the ER probably wasn't always the best.
I was an application assister years
Yeah.
ago under a previous iteration of major change that was controversial. And I sat at rural libraries all
Mhm.
across Josephine County talking to folks, and nobody knew they were eligible.
I'm
Nobody knew
sure.
what it meant.
Yeah.
People had the wildest questions and things they had heard, and it was quite the education.
Yeah, and along those lines, we'll need to prepare the system for what it is now to receive newly covered folks. Yeah, so there needs to be navigators and get back to work for the force. We're to prioritize. Oh, we can. Yes, yes, yes. Yeah, what's hitting us the hardest? I really think it's sort of like, ooh, God, we need to get to this next month. They're falling off. Correct you.
gets to like, what are the dependencies? Like, we can't get to our work until you get to that work. Is there anything sticking out right now? All things, all at once, okay.
I would say defining the regional entities, I think
Yes.
their role is, and I don't know if it's number one, but it's up there in the top three. on that.
Mhm.
And defining the payment strategy. You gotta do those two things.
Yep.
Pretty quick.
I think it falls closely on the heel, like what does the delivery system look like?
Mhm.
Yeah. Right.
A little confused as we talk about the priorities. I mean, I agree, those three things are real priorities. But how does that link up to some of the work that's currently being done, like figuring out how to finance this? I'm just a little
Yeah.
confused.
So part of the reason why we're doing this process is because when we started, we had a work plan and we just divvied up all the tasks and assigned them to all the committees. And so what's happening now is that within our committees, they're wondering if it's their responsibility to come up with a payment strategy or how regional entities work, right? And so what we're trying to do is step back and say, okay, these are the pieces of work that need to happen, but maybe some of them don't happen at the committee level. Maybe some of them have to happen at the board level, so that we can give the committees more specific guidance on the problems that we're asking them to solve. So that they're not sort of taking on sort of the whole sort of construct of the plan.
I get that, I'm just saying, can we put things that are currently in the committee, that
Yeah.
aren't on the board then?
Yes.
Yeah.
Okay,
Mhm.
then I would put on there, how you're gonna finance this.
Finance.
Yeah,
Yeah.
I didn't know whether when she put payment strategy, what she meant, but
Yeah.
okay, so finance, yeah. Yeah. Pay for this, yeah.
Model, structure, process.
Well, I can put it in, I mean, so
Yeah.
we have you've got your cost target is one of the, I'm just kind of going down to the list, but then you also have the finance strategy. So the finance strategy is, what changes need to be made to the current system to be able to enable this, but then the cost target. And the cost target is dependent upon the sort of benefits and eligibility in the payment structure.
I was gonna say benefits also.
Yeah,
I mean,
yeah,
'cause-
absolutely.
Yeah, let's get that
Yeah.
nailed down.
I just didn't know what could be in play, so thank you. I thought it was only the things that were in the middle there.
That's great. So now we've defined a little cluster of things that are absolutely codependent. So let's do the hard part and piece it apart. Whose job is to come up with a financing strategy? Is it the committee? Is it the board? Is it the board via committee straw proposal?
Yes,
Yes.
that one.
Yeah, okay.
A help of consultants.
Yeah, right.
It's a good thing.
Okay.
Okay, and then these arrows, that intention here is that there's communication back and forth and it's a give and take, but the hard work is yeah. Okay, how about who figures out what's the cost target gonna be? Are we gonna rely on somebody else? Do we need to come up with that process, model, line, whatever you wanna call it?
Well, is that a contingency? I mean, that's what I'm,
Is it? So that's a great question. Yeah, who decides that?
that seems to be, I would recommend, that would be a board question. Do you decide how much you want to spend and then build your plan around it? Or do you build your plan and then decide how much it costs?
Well, and we've already given
Yeah.
that recommendation to the board.
Mhm.
I mean, just kind of a ballpark figure at this point, but yeah.
Benefit structure.
Right, and
Yeah.
we've taken the stand
with this board, that first we're gonna figure out the financing strategy and then figure out what that can cover as a way of containing costs. And just to check in on that, is that still kind of, so you can do it both ways. You can say, what do we want to cover? And then let's figure out how much money we need to pay for it. Or you can say, here's how much money we have, here are the limits of what we're willing to spend and the growth limits. And what can we pay for within those limits and how do we decide? So there are two reasonable ways to go about it. We've always gone for the latter to say, what is a reasonable financing strategy? What kind of revenue, what kind of revenue could we come up with? What are the limits to what we're willing to spend? And then what can we pay for with that money? So that's been our stance to date. And I went and spoke to the finance committee and gave that information to say, we want you to come up with a revenue strategy first. And then we will kind of limit what can be paid for based on that, because our priority is limiting cost and cost growth. And so first we find our financing strategy and our cost limits, and then we come up with what we pay for. But I just want to check with this group that that's still where we are. We went that way because our priority was cost containment. That our main problem that we're trying to solve is the unsustainable costs. And so if we create a feasible revenue structure and cost containment, and then build from there.
That's what we understood our marching orders to be, although it's kind of revolving around this plan, but I mean, with that in mind.
Yeah.
Can we just define cost target?
Yeah,
I'm a little confused because I think it means a lot of different things to different people. It can mean how much a system's gonna grow year to year. It could mean how much a benefit package costs. What is it? What are we meaning it to be?
Kind of was mentioning there's a two way to approach that. One is starting from benefit and see how much it costs. The other is starting from how much
And
revenue we can generate, and from there to limit the benefit.
So the cost target is the total amount of money that we want to spend on healthcare.
Yeah.
And how much it would change year to year.
Okay.
How much would, so both of those things, how much would change year to year? It's not a cap. Like now we think of cost target is like 4%, right? Is that the?
Yeah.
Yeah.
That's what I'm trying to figure out. Is
Right,
it a
right,
growth
right.
target, or is it what something costs?
Yeah.
I think it would need
We're
to be,
using,
that's
I'm
an excellent
confused, we're
point.
using it, different people are using it both ways.
So Mimi, this was your term. Did you have a response to that? Or?
So I do, I mean, I agree that it is, well, and that's what is actually called out in the work plan is
Yeah.
the phrase cost target. So I think in order, and Kim can hop in here too, and Cheryl as well, and Mary Lou on the Finance and Revenue Committee, is that in order for our consultant groups to be able to deliver sort of their potential model, I think that this, it is a contingency. If there has been a specific cost target that is agreed upon total cost of care and also.
So it's a plan cost.
So plan costs and also incremental increases per year, so then they can develop that structure, and if that has already, if that's been clearly decided upon, that is a
Well,
question.
we had a straw proposal, and I'm forgetting the exact cost, but it was for the total cost of the health plan, starting in year, I think we decided now 2030.
Okay.
Yeah.
And then currently our state cost growth target program, I think they still use the 3.4%.
Yeah.
And I know that
Which is
was
a
kind of.
fictional number.
I know it's arbitrary.
It's
arbitrarily decided.
It was 2 percentage points below what medical inflation. was. It
Inflation,
was
right.
never
Right.
3.4%.
Right.
I mean, I just gotta continue to clear that up.
Right.
So the question is that the right rate of growth? Is 3.4% how much the cost should grow each year, or should it be different than that?
I mean, has that, can we look at the evidence of how that has worked so far and make a decision?
We haven't talked about, we haven't explored that.
You peg it to other economic indicators, not.
Something real.
numbers.
Yeah, I mean, I think to bring our principles and values into this, if we want this plan to be sustainable, not just like really for the people, right? We want it to be something that creates meaningful access over time, which means it has to be stable and sustainable. Which means that, yeah, it needs to be tied to real numbers. And I think in Oregon, my personal observation and opinion is that sometimes we are very aspirational. And we try to ignore that part, and that actually reduces access over time. Instead of increasing it, and so, yeah, I think we maybe work with consultants to figure out what it should be times two. I don't know, do we know the answer?
But which economic indicator should the rate of growth be?
Right,
Okay,
so
that's a question.
on the consultant list.
Got it.
Yeah,
It's on
yeah.
here, actually.
It's on there?
Yeah, yeah, you're so smart.
And there is also one big unknown factor in assumptions. That is with the universal health plan, potentially and presumably, we can cut down the cost. So, but that right now is unknown, particularly the administrative cost and other ways that a single system is more efficient than multiple non-system working with each other. But right now, we don't know how much that's saving.
Yeah.
Potential, but there surely will be saving.
Right, and that's been part of what, as I've entered into the finance revenue discussion about on both ends, the provider and the payer, how big is that? And how much savings does that give us? They can use them for the other things that we're saying we've gotta have.
Right, but not to beat a dead horse, one is the cost of the system and how much that will save because
Yes,
we have a single system.
right,
The other is then how will cost grow year
Yeah.
to year?
right,
And how do you make it so it's sustainable?
yeah.
And we haven't really talked about that in the finance room today. I put in there. Put that on the agenda.
The sustainability and what it should be.
The cost.
Tied to,
of-
mhm.
Yeah.
My hope is after I'll go through and sift stuff out and things that were quotes signed to committees, send it back to you, be like, the board has questions about this, or we're gonna cross talk about that. Yeah, sure thing. 4 priorities: define regional entities, payment strategy, delivery system structure, and the financing strategy. What else?
Can I ask a question, which I'm not, it fits somewhere in the finance, and I'm not sure, I haven't followed all the conversations, but the big unknowns of federal funding that we are dependent on, and that I assume this plan is dependent on what is currently that we are on page funding, like, so how, like, are there different models with different
Mhm.
contingencies based on the most
Yeah.
current info?
We all agreed we need some kind of worst case, I call it a worst case
Mhm.
scenario, but a contingency plan, exactly.
Okay.
Can I add something to the priorities?
Please.
And I defer to Michelle or wordsmith it, but some communication is a
Well, that's-
priority.
Yeah, all of this, our work is dependent on all of this, so I'm kind of waiting for this to get settled, like that's whatever
That's what I was
needs to
thinking
happen
too.
for the plan drafts to be finalized, and then our work comes in as a contingency.
Okay,
So for instance, we could take up the idea of regional entities at the board and like, right now, the legislation says that they don't bear risk. That they are administrative structures that function right and they don't bear risk, but that would be a pretty major change to how it currently exists, and that would be a really interesting thing to shop around.
Yeah.
You know, like how would that work? How do CCOs currently work in terms, CCOs currently have a global budget and bear risk, right? And so that would change things pretty dramatically if we're building off of that model, and how feasible is that? How reasonable is it? Like how, you know, and then if regional entities do bear risk, what would that look like, you know? So once we figure out like what we want, or maybe come up with several different models, you know, then that would be something to give to the communications and have them shop around and saying, you know, if there were shared savings, but you didn't bear risk, like would that work? You know, or like how does that? So we need to make some decisions first, and then when we want feedback on that, say, can we talk to current CCOs and see how that would play out, or?
Yeah, the one thing to know though is that we basically have funded and contracted for 10 engagements. Basically, with the list of priority populations. And so if we say, okay, here's our draft finance and revenue plan, here's our draft plan design concept with whatever variations we want feedback on. Take this out with Artemis Consulting and engage with employers, healthcare providers, CCOs, et cetera. And we do that. And then 3 months later, we say, okay, we're gonna define regional entities this way, but we're also thinking about that way, we wanna take it out. We would have to then be figuring out how to pay for that.
We need to be thoughtful about like.
So the
let's set a
timing-
question, right, yeah.
That timing is very important, and so right now, the draft plan, based on what you just described really well, Helen, about last year, we took the pie and we divided it up, and we've all just been trying to eat the pie. The idea was that we would be doing that this summer, and so I think part of what I'm looking to see through this process is what is the probably more realistic timeline to get to what you're saying, Bruce? Like, when does communications come in? When does engagement come in? So that we can let folks know and also like committee.
Yeah, no, it needs to, yeah, I just wanted to
Yeah.
be up there as a
Yes, yes,
priority.
and I'm agreeing with you, yes.
Right.
When it happens and how and.
Yeah,
I think my question is like, are these 4 things the only 4 things that need to be up here to get there?
We haven't finalized eligibility.
Yeah, eligibility,
yeah, we don't know.
We're pretty close. Are we
is that,
finalized eligibility?
We're pretty
Sprinkles
close.
are working on the straw proposal,
Yeah, yeah.
and it's already come back to the committee a couple of times, but I think they're still in the, have at least one more go round.
I'm guessing June, we would have a eligibility proposal, yeah.
And then that will come to the board.
Yeah, for the board, yeah.
Well, good point. We need to know
Yeah.
eligibility,
Yes.
benefit package,
Yes.
how we're gonna finance it. Those are the key pieces.
One thing we want to envision is we think about the near future and those plans is, let's say, on day one, say 29 or 2030, on day one, when this plan started operating, what need to be in place?
yeah, and but also, I think to the point that Bruce was making, and also like how I'm seeing this, in terms of priorities right now, my question is, what needs to be settled enough so that we know what we're asking to do some engagement? So that's like an interim step before that, before what you're just, what I interpret is what you're describing.
And are there questions that would be ready to go for the summer? Or do we need to delay that timeline? That's kind of how I think about it too. So some of these are very big questions.
Yes.
Right? And we may not have them sorted, in time for the summer engagement, but are there other things?
Well, and the summer engagement can shift.
Yeah, it doesn't have to be we don't wanna.
We had, what the original,
Prematurely engaged.
what the plan said was that June, all these plans would be done, and, I don't think that that's.
Yes. Yeah.
Yeah.
So we need to shift our work to accommodate this work really being
Yes.
ready.
Yes, yeah, because prematurely engaging would cause harm.
Would cause harm, yeah, absolutely.
Right. Okay.
So at the very bottom of the
Yeah.
page, can you put strategic communications and engagement?
Communication plan number 4, yes.
Or yeah, maybe put engagement at the very bottom.
Yeah, so in the meantime, while we're waiting, we will be working on things like static,
Yeah.
preparing things, yeah.
That's good.
What was your alternative for citizen direct?
Oh,
Local health
yeah, the
engagement.
local health engagement councils.
I guess I wanna suggest and check this with everyone, Amy, like it's less about waiting for plan design to come up. I don't think it's right for plan design to kind of make these decisions, right? I think this is a conversation we should have at the board level about how we wanna do this, right? So it'll be all of us kind of
Yeah.
figuring out like we can maybe present a couple of models and say, if we wanna go with this kind of thing or this kind of thing and talk it through and have our consultants weigh in on advantages and disadvantages, but this is kind of like, the board needs to give our committees a lot more. And it, like, in the same way we need to give CCEC committee guidance about what to engage on, the board needs to give plan design a little bit more guidance on kind of a clearer structure and parameters for the future stage, so.
So what does that look like? Does that mean that that conversation would come to the board for our next board meeting, and that would be the kind of focus for that meeting? Okay.
Yeah. exactly. Start making some decisions and, and get input, of course, from our consultants and our committees, but we need to start, yeah, making more clear decisions about it. Just call out too, that I really appreciate this group, and like, I know it feels like, we've been gathering for a year, but we've had a complete changeover in staff. It's like literally our entire staff left and got replaced, and so, and we're all volunteers and doing this work on our own time, including the work of the board and the committees, and so I just want to just call out, like, we've done some incredibly good thinking, we've got a lot of good things in place, our plans are, our committees are really doing well, I think, and considering all of the setbacks and constraints on our work, I think we're in a really good place, and this is daunting, and we've got a lot of work to kind of do in the next year. I am hopeful that we can do it, and I'm just really grateful again for our new staff who's come on board, and I think it's a great chance to sort of re-energize around this work, and we will be much more focused in the coming months. The past 2-3 months have been very difficult because of our staff turnovers. But I'm confident that having this in place, we'll be able to move quickly and get a little bit farther along the next few months, so.
You'll feel like forward, not spinning the wheels.
Yeah.
Well, lunch is here at 12:30, but it feels
Lunch
like
is
we're.
here.
Oh, it's here? Oh. Okay, so I'm gonna take, yeah, you guys are.
Okay, welcome back, everyone. We will, we need to do a quick roll call. This, lunch.
Can I do a visual roll call? We're doing, we need to do an official roll call. Alrighty, official roll call. Helen Blanca.
Here.
Chen Wei Chi.
Here.
Amy Fellows.
Here.
Michelle Glass.
Here.
Bruce Goldberg.
Here.
Judy Richardson.
Here.
Cheryl Ramirez.
Here.
Mary Lou Henry.
Here.
Excellent.
Awesome, thank you.
Gang all here.
Great. I'll hand it over to.
Great. So at this point, I just wanted to recap. Did we have any other committee members join us?
They might be waiting till 1 o'clock
Oh, yeah.
We said 1 o'clock.
because we said 1 o'clock. on the
Great.
thing.
All right, so we get a preview before
Yes.
they join us. Good work. That was a lot of work this morning and, good work being present in the chaos. Because my intention was to hold space for that and work through it. And if we go back and look through what we've done this morning, I think you'll be surprised, like I was, that there's a lot of synergy and, it feels like we're on the right track. So as we started this morning, we were really unloading what is broken mostly about this system and probably what calls us to this work. Or at least what calls you to your committee assignment or brings you into volunteer on a day like today. In current state, the sticking points, the pebbles in our shoe, these grains of sand that we just want to get out of our eye about the current system are that costs are unsustainable and threatening the viability of hospitals. There's regional inequality, and we drew this as a road going off the cliff of cost, unsustainability, and then looking at sustainability cliff being right as one of the main things we need to address. Uncertainty via federal politics, policy, chaos going on, financial burdens to families, individuals, businesses, households. Our system is currently fragmented and inaccessible. We have poor outcomes despite how much money we keep throwing at the system. Huge health disparities, admin costs are high. There's multiple repetitive, redundant elements to this quote system, although it's not even a real system, but it's redundant in a bad way, redundant in an inefficient and wasteful way. We talked about the impact of complexity and jargon creating barriers, and then people reaching out to things like Dr. Google and ChatGPT and AI to get some help for health conditions that they can't access care for. We talked about the challenges with the workforce, compounding access and wait time in the chat and Google GPT. Lack of trust in the system, in
public, in government, and perhaps healthcare and healthcare providers as well. We're still looking at the post-COVID residuals and impact of the public health pandemic. The system is built and woven with structural injustice and inequity. We don't have a shared understanding of what accountability and responsibility means when you have a public entity or government or healthcare being accountable and responsible. Current system, many folks are tethered to their employer or they're tethered to the state because they have those state linked or employer-based healthcare. We're not a functional system. This a disparate system scattered throughout. Some are connected, some are not. So no one's accountable and there's no governance. And I think the worst thing that hits home for us is that the system causes harm, whether that's financial, whether that's perpetuating injustice and inequity. Lots of ways. Okay. Got it out of our system. There's probably lots of other ways it's broken that we could talk about, but let's focus on what we're hoping for the future. We started aspirationally. So clearly we want a functional system that can be equitably, reliably accessed and doesn't cause harm. And access includes where and when. It has excellent health outcomes and it's got simplicity with as much as that is possible. There's cost control. It's not an out of control system as far as costs go and spending, and it's not profit driven. That on the road, I hit that one. It's a for-profit, and for-profit is driving us off the cliff. But we're reliant on the state general fund. Success is measured one way. It's known how we measure success, and transparency about cost and outcomes. That's clear. It's all metric set. Also, specifically, we'll have a statewide communication campaign that describes what this is, who it's for, why it's here, how it is sustainable in plain language everybody understands. It's set up by a public trust and a public corporation that has defined responsiveness to accountability, governance, and ownership. Delivered by regional entities, and the square boxes mean these are established for us. These are given for us. State bears risk. So we'll talk a little bit about the board's discussion on these elements. Providers, the institutional providers are under a global budget. There's behavioral health enhancement and population health coordination under a single plan and a common benefit plan. There's transparency for costs. So we talked about those things that our committees and the board can do that are perhaps resilient and will live beyond and maybe separate from our work, and perhaps even as the impact of our work can be to establish those stepping stones. And so we talked about behavioral health code and payment reform, and this is decreasing the administrative burden and coordinating things that are already happening perhaps in the state to improve behavioral health payment. But hopefully we can do so in a way that helps further our own agenda. And this includes also building the access point of primary care either through the CB or CCBHCs or PCPCH model. We'll talk about that in a minute as a question to clarify. It has community governance so that there are local health engagement councils that are established. What a wonderful way to get engagement for what it should look like. Non-emergency medical transportation and emergency medical transportation has been reformed. We figured out the system. At least we can give some instruction about how that should look. Is there a capitated limit on how many times you call emergency, or how do we encourage people to access it appropriately? Because right now it's inefficient. Perhaps there's policy that regulates health plan reserves and a single state formulary for prescriptions. Plain language communication points is echoed throughout. A uniform fee schedule and reference pricing are established body of work. Public option for both long-term care, nursing home care, but also care that keeps kiddos in their home who need extra care. Perhaps we'll look to the Washington model for that. Style guide, this gets back to communication and language in a consistent way, which builds transparency. It's so integral, right? A policy about limiting out-of-pocket healthcare costs to 10% of the income and global budgets for hospitals. In the ether is the current
high income tax and the business model of healthcare, as well as the federal administration, and perhaps a debate about whether or not healthcare is a right or a luxury, I guess would be the other option. Yeah. So those are the stepping stones, and the things that we're working on now, I think all of these will get us to the brighter future. Appropriate use of quality metrics, figuring out what those are gonna be, establishing eligibility. And we didn't talk about attribution too, but if there's regional entities, we need to think about who's responsible and accountable for those folks, right? Cost containment strategy, addressing long-term care supports. Communicating with our West Coast buddies, Washington and California, at least learning from each other and then figuring out what happens when you have, people who go across borders. Building the workforce. Core plain language talking points and engaging stakeholders. Defining the benefit package and provider payment strategy, as well as whatever you want to call a universal permission to keep our money and get our money back from the Fed support, whether it's a waiver, whatever that is, so that builds resiliency against the variability of the four-year administration. Cost calculator, it's easy. I feel like I want to put the Staples button there. That was easy. I'll see it. Establish a public trust. Okay, so those are all the process steps that we believe need to happen to get us over here. And if these things happen, boy, they're going to stay there forever, and that's great. So some key priorities coming out of this meeting is we as a board should really figure out, what does regional entity entail? How are they accountable? How do they demonstrate transparency? Is that cost? Is that quality? What does that look like? And those regional entities, how does that build and fit into our ideas of the public corporation? What are the key elements of the playbook? I love this new phrasing now. It's not a plan, we're giving a playbook. Use it. What's nice to have? What do we need to have? And what, like outside, it's falling off the buffet table right now. Nope. Cost containment strategy. How are we defining cost containment? And what's the strategy around that? Is that the total cost? Is that the growth, the acceleration of growth? How's that defined? And then fourthly, how will care be delivered and improved upon? What's the model that it's built upon? Is it the patient-centered primary care home and medical neighborhood model? Is it something else? How is care delivered? How do people access care? How do we do it? Implicit is that in that is provider payment. So for the committees, actually consolidated the lists we have because there was a lot of redundant things and things that were already happening, but plan design detail, including dental, was called out. IT system for ops will be an eventual discussion, and whether that's cost, like a billing type IT system, or if it also includes health, like in Taiwan, so you have a universal access to your healthcare record. Community engagement councils are going to be super important work. And then we called out, thank you very much, the dependencies and like order of operations, if you will, for the priorities here. Thinking that defining the regional entities, so that's up here, regional entities, payment strategy, the delivery system structure as above, and then the financing structure. What's the financing strategy? And that includes the cost target in that fourth priority. Plan for the cost and the growth and benefit structure. And then once we have some consolidation around this, we kind of know what we're talking about. We're going to need to engage and ask our folks in Oregon. How does this feel? Shop it out. If there are options, what did they think about the different options? Such as, yeah, the revenue that comes before the spending. So establishing what the revenue structure is and then establishing the plan design via cost containment. And then asking the consultants, is this current growth target really right for us? How else do you measure economic success and outcomes? Number 5 is establishing eligibility. If you don't see it down there in engagement. What did I miss? What's missing? Yeah, thanks, Helen.
Timelines.
Timelines, yeah. Okay.
Both in terms of like when the board needs to kind of settle on some of these
Yeah.
priorities, and then taking a look at the timelines in the work plan. For each of the committees to say what's a reasonable timeline for some of this work to be done.
How would you like to proceed with that? Do you want to put timelines as the priority, or do you want to talk about our current timeline? Do you have that to live in life?
Maybe we can just, check in with each of the committees on the timelines that are currently listed in your work plan and get a sense from you about where you are in that, and if those are reasonable, and then we can talk about some board timelines for when we need to make some of these decisions.
Finance, how are you feeling about the timeline for your deliverables?
I think we're pretty behind.
Mhm.
I gave that specific feedback and so I don't have I don't have all the details. I was gonna look it up really quick. I mean, just in general, I think we'll need to meet longer than we were anticipating meeting, so
I didn't mean to put you on your
Yeah,
spot, on the
maybe
spot. I
through-
did read your timeline details,
Okay.
absolutely. I
maybe
didn't bring them.
through, I don't know, September, October.
That feels.
Design is currently slated through November 2025. We're making pretty good headway, I think. I think with some of the board decisions that I'm guessing are gonna happen in the next 2-3 months, that's probably pretty good for November 2025.
How does the iterative process? So like. When we are at the point where we work with our consultants and we take it out to the key stakeholder groups that we're obligated to. Get feedback from, then. Would it not go back at all to financial plan design? Would it just come here, that feedback? I'm just thinking like. Is November, like when you stop meeting and that's your goal date for. The first draft of the plan that we begin. Getting feedback on. Then what happens after that?
Right, so the timelines were for the deliverables. It doesn't necessarily mean that the groups would stop meeting.
Okay.
You know what I mean? It's just like, this is when we are hoping for certain deliverables to happen. I wonder if what we should focus on here is reworking this work plan and being more specific about the tasks and then pulling things out that we think need to happen at the board level or with our consultants. And being more strategic about like the actual tasks of the committee. And then taking a guess at the timeline, working with each of the chairs. And then confirming that maybe at our June meeting, kind of just trying to do a revision of that. How are people feeling in general about the timeline of September 2026 for this together?
For initial draft plans. Is that what you're saying?
For, to be done.
For 2026.
Oh, 2026. Sorry.
I would say that's okay, as long as we don't have to build in so much time for the reports. I mentioned this in my feedback, like. The consultants wouldn't have 3 months to do their report. And then there was the other, I think the final report or whatever, that there was like 6 months.
That's right, yeah, she put a
So we
lot
have
of
to push that,
padding.
yeah.
Yeah, there's a lot of padding in there at the end. Do the chairs feel like you could, based on our discussion today, kind of rethink what's listed under your work stream? And identify the tasks that you feel like the committee can do versus the questions that need to be bumped up to the board or sent out to consultants? And then kind of make an assessment of a revised timeline.
For finance and revenue, it wasn't about our tasks, it was more about understanding the consultant work and
Yeah.
understanding like how far we could push the committee back. or, I don't know if that's what we're, but how far we could push the consultants to their report date, like in our case, as I recall, Echo Northwest was going to have between October and December to get their report done or their analysis done. And the question would be is whether the committee could keep working and they don't have like the full 3 months just to be working on their report or no. And I don't look at the timeline, so I don't know if that was changed, but that was my feedback. It wasn't about changing tasks, really. It was just about moving the timeline and allowing us to meet longer.
Okay. Yeah, and I think. Oh, yeah, you're back there. I think Echo Northwest has kind of drafted a rough timeline for the next few months, and so maybe looking at that and coming up with who's doing what and can we be done by this date, that should be pretty straightforward.
Operations, I just think it's gonna depend on the ability of the consultants to. I don't know what their timeline is. We're on track, and if they can deliver a product, we'll be okay.
Yeah.
I just don't know what their timeline is.
Can you
Right.
sort out from this list, Bruce, what you feel like the committee itself is doing versus what the consultants are doing? And Kim helped with that too, she kind of really have the scope of work from,
I think most of it now is from the consultant.
most of it is, okay. Say that pardon me for interrupting, but so Millman, their final report is due March 31st of 2026. But their a draft report is on revenue impact, which is kind of their biggest and main deliverable, which will impact the finance and revenue committee. Their draft report is due February 20th. Now, obviously, we're going to be working in the interim. And we'll have deliverables, prior to that, but just to kind of level set a little bit. And then Echo Northwest are through October of this year. Is that right? Or is it December, Kim?
Final reports due October, November.
Okay, yeah. October or November?
It's like the draft.
Oh, draft event, so November, yeah. Maybe once, she's not here anymore, but her plan was to work through December of this year. Artemis, are we?
We've had Diana kind of on hold. And wouldn't we?
She was scheduled to come back in May based on the
June.
idea of June engagement. So there's some work that she can do with us on the committee and Patty wants around. Identifying the granular specific exact groups within those stakeholder broad categories that we would do that engagement with. And prepping some of the questions, but I don't think we wanted to do much question work at this point.
Yeah, but I mean, does she have a backstop limit? Like, so if we kind of keep pushing her out, does she have a date where she can no longer work for us? Like, we have her
We need to
until.
check
We
it.
would
We can look at the contract.
Yeah, need to
I'll
check.
pull that up. Check that, 'cause I want to respect.
Cause I
Yeah.
think initially she was contracted through fall maybe, so,
Okay.
yeah, we
Yeah,
need to
Yeah,
check.
check you guys.
Yeah.
And then HMA is through. No, through July, yeah. No, it's this one.
Oh.
Okay. So let's, so maybe we'll, Kim has done a ton of work with overlapping the tasks and, roles of the consultants and the committees, and we'll kind of look through that and use that to revise the work streams and the work plans for each of the committees. We'll take a guess at adjusting the timelines and we'll get those out to you. And if I could ask that when you get those, if you take a look at them right away and get them back to us. And I'd like to try and finalize them if we can in our June meeting. If we can get just a rough, yes, no, this looks right, or what needs to be edited, so you'll see those in your email in the next or two, and then try and get them back before our meetings, we can discuss at our next board meeting. Yeah.
Can I ask a question? So for the June board meeting, if the board is going to be discussing these topics, or do you anticipate the board is wanting to discuss what does the regional entity entail, key elements of, cost containment? I'm wondering what types of, information that the board would like from staff that we can bring to that to facilitate that discussion. You don't have to decide right this minute. Or if you feel like you have enough already, but just to kind of keep that in mind, if you wanted to address that in order to facilitate the work of some of the other committee works, or make it a little bit more clear. But again, that's just throwing that out there. People can certainly.
I'm wondering if in our June meeting, the piece that we take on is, I have to look here, 'cause I can't see. The delivery system structure and payment. Partly because obviously the financing and revenue part is key, but Echo Northwest is just coming on board, and I'm anticipating that we would have them come to the board July-ish, August, to give us like a sense of where they're headed. But for June, I wonder if the design of the system, like how it actually works, how it would be built and delivered, and how folks would be paid would be something we could take on in June?
Yeah.
Or do people feel like we should start somewhere else?
So care delivery system and payment strategy, sorry, I'm just trying to make sure that
Yeah.
I'm like 100% clear.
Yeah.
I guess my question would just be if we have several next steps coming out of this strategic planning session, and if one of them is each working group is going to be revising their work plans, then when does that report come back to the board for discussion? So we're all on the same page about what might be shifting in order to accomplish this, and then how do we also make space for these deep dives for board decision making to support committee work?
Right.
Does that happen in July then, that we bring back our updated work plan sections with tasks and objectives?
Well, I'm gonna need to look to staff to see how feasible it is to revise work plans and get them out before the June meeting. I don't really
A good point.
know that, but
The cadence of the committee
The-
meetings, it
yeah.
might be July, yeah.
In terms of the bigger decisions coming to the board, I think that's gonna just depend on how the information comes to the board.
yeah.
I mean, if things are, if it's, gee, what do you guys think?
Right.
I don't think that's gonna work very well. If there's enough time to have some information in advance with some background, some options,
Right.
then I think it would work.
And key decisions identified that are needed, yeah.
Exactly.
Yeah,
Yeah. So which of the priority topics do you think is most right for that?
We have define regional entities, payment strategy, delivery system structure, financing strategy, and establishing eligibility as priorities.
There's been a lot of work done on the eligibility.
Yeah, there'll be a strong proposal in June, so.
So that seems like that would be.
Say eligibility number one, and maybe regional entities is number two.
Certainly get just some examples and go through some of the literature and present to the audience.
Just thinking in terms of ease.
Yeah. Okay, so we will handle eligibility and possibly updated work plans in June, and I'm gonna confer with staff on that versus July. Well, I think. Maybe, go ahead, Judy, you have to help me.
So this will be an interesting question. So we will actually have access to an expert in a few minutes who designed regional entities, or like, we can pick his brain and talk about it. That'll help tee that up.
Yeah, so maybe we could start on that piece if we, yeah. Absolutely. Yeah, let's do that. Let's do eligibility and sort of an intro to how the CCOs were built and how regional entities might function,
Mhm.
what the options are, what questions we have, what priorities we have.
Can
Yeah.
I have a question to consider for that? Of course. With the CCOs, that's something that I have in a conversation with Summer about, but, the way they ended up was that some of them are allowed to be for profit and out of state, managed by out of state boards. And so I guess the question is if we would revisit that, like, I understand that was a compromise that happened in the legislature. Not the way it was intended.
Yeah, that's exactly the kind of questions we would take up with that discussion is what do they look like? What do we want from them, right?
And also technically regional.
Yeah.
They're not
Yes, they're
metro
not.
area.
Right, so can they overlap and how
Yeah,
many?
one of
do
them
we
that's in
need?
my region has moved to your region.
I know, yes,
Right.
thank you. Anyway. Thank you so much. But I think those. I guess we just kind of want to conceptualize what we really believe.
What we believe
Versus how do we just kind of go by retooling something,
that
whatever that's. Maybe not.
ended up as a compromise.
Yeah.
We don't want to compromise on the compromise.
Right. And do we have, you were mentioning, Helen, that the legislation says they will not be risk bearing. And I think that totally changes
Oh, exactly.
what they'll want to do or whether they want those same ones, et cetera, because I think that's part of the game.
Yeah, right, so we need to think about that and talk about that. Yeah. Okay.
Does that tie directly to policies regulating their, well, I guess they wouldn't be health plan. Well, I don't know. Would that tie directly to regulating health plan reserves?
Yeah, probably.
I think those are linked now.
Yes.
So there's one
They wouldn't be health plans.
I know, that's what I was.
Yeah.
So one idea is as a stepping stone, if the universal health plan does not exist, would never exist. Independent of the
Yes.
universal health plan, one idea is you could think about regulating the reserves of health plans. That's like a stepping stone, meaning it's stands alone regardless of what happens with the universal health plan. But dealing with the reserves that are currently in the system is necessary if you're gonna build a plan like this, right? And so like, that's what we need in stepping stones, like, it could exist by itself. So you could, like, as a policy decision, you could say, should we be regulating the reserves of health plans? And if so, why, and what would that look like, and how would you do that, you know? So, but then they would all be pooled or something, I don't know, at the state level, I don't know anything about. But you know, how would that work to have reserves at the state level, or would they be at the regional level if the regions are bearing risk? I don't know. So, yeah.
Yeah, it just seems tied to the risk variance question.
Yeah, absolutely, yeah. Because whoever bears the risk is gonna have to have the reserve.
Yes.
So anybody else have thoughts on priorities, timelines?
Thinking too, we probably do have some committee members.
Yeah.
Excellent.
So I don't know. We invited our committee members to listen in, especially to this recap portion, and let us know if they felt like anything in particular was missing or that we hadn't considered in our work that they wanted to chime in. Do we have anyone?
Any questions? We've done.
Yeah, they could maybe,
John?
Yeah.
That's great.
Yeah, I mean, can we,
Oh, sorry.
Can you hear me?
Can't hear you.
Can you hear me?
Yes.
Well, I've watched intermittently this morning. Thank you all so much for what you do. This really is an incredible task. I didn't see, all the morning, but I did see the summary. The one issue I think I'm not certain you're appreciating the gravity of it. It probably comes under payment strategy. In the task force, we called it normalization of payment, i.e. that payment would be the same for Medicare, Medicaid, and commercial patients. That results in a transfer of $10 billion, 20% of the plan's money transfers. I suspect, for example, that a lot of those hospitals who are in trouble now will no longer be in trouble under a normalization of payment, because they're in trouble because they have a, if you will, a bad patient mix. They have too many Medicare and Medicaid patients, and there's nothing they can do about it. They're mostly rural or medium-sized, or they managed to make the right decisions such that they ended up in suburbs of Portland and Eugene and Salem, where they got good selection. That's a huge issue, and I think that there's, in terms of your communication strategies, there's, I think, going to be enormous benefits as a result of that. But you can imagine some of the folks who have, if you will, played the selection game well, are going to be concerned about that. I just didn't hear that articulated as much as I thought I would, and just put that out there as something to think about more, because it is going to be a headline. And by the way, I think it would absolutely be something that would be of interest to the federal government and waivers and all, to see what would the effect of that be. Nobody's ever tried that in the United States. That's an incredible experiment. Thanks.
Thank you, John. Isabel, you're in charge of who's understanding.
I do think that we did bring it up, maybe John wasn't listening in that moment, but it is on our list.
Yes.
John, we've talked about it and it's clearly there.
Yes.
I added it again.
I have a question or a comment. So I'm Colin Stackhouse. I'm on the Community Engagement and Communications Committee, and responding, Michelle, to your, one of the green check boxes at the top is that the statewide communication campaign, other people will start to communicate, and Healthcare for All Oregon has started doing a lot of communication about this, which is great. We're excited to do it. But now with the shifting timeline, I came in a little later after lunch. What I have said as recently as maybe 2 weeks ago is that by this summer, the first draft of the plan would be available, and then the communications committee between January and March of this coming 2026 would be doing our intensive 10 obligatory like outreach, moments to people around Oregon. Was that correct 2 weeks ago? And that's no longer correct.
So at the last, great, thanks for being here, Colin.
Yeah.
First of all, and then also, yes, so at the last board meeting, this question came up, and based on the information that we all had at the time, it was confirmed that the draft plans were still targeted for June. But we were all also kind of waiting for this process to revise the work plan. So yes, your information was absolutely correct as of 2 weeks ago. You were in the loop. Thank you for doing that communication. And so the timeline will shift for when those draft plans are available based on the conversation today. But I think if you were telling people that it would be like first or second quarter of 2026 that we would be doing engagement, I still think we'll probably be doing starting engagement before then. So I think that this is the iterative work.
Okay.
But yes, you were correct 2 weeks ago, and now things have changed,
Yeah.
so,
Okay, great. Thank you.
Gonna be honest and accurate and on time, maybe.
yeah.
Okay. Well,
Do you have anyone else? No other reason. Great. Okay, well, our next guest has arrived. It's my pleasure to welcome Governor Kitzhaber for our next agenda item. Y'all know Governor Kitzhaber has been elected as our governor 4 times and was really instrumental in developing the Oregon Health Plan as well as CCOs in Oregon. And he has generously agreed to participate today to offer his perspective on our work. So good to have him.
but I'm not responsible for this part.
Maybe take yourself or put yourself on the camera, then I think we'll see the people virtually will also see.
Let's see.
Governor Kitzler.
Yeah.
Yeah,
Perfect.
perfect.
So, and on camera, you can't see yourself.
Forward right here.
Yeah. I think we're gonna, we might have to like, right here, then, with your, sorry. I know.
What do I do here?
Here, I'll be here. You just tell me when.
Sorry about that. Well, thank you very much. I want to thank Ellen for asking me to come down here and spend some time with you this afternoon. What I want to do is to try to put this important work that you've undertaken into a larger context that will hopefully help inform your decisions and your thinking as you move forward to carry out your charge. I know a lot of the people here, and I know that we won't agree on everything, but I want you to know that I am fully committed to the goal of timely, universal access to quality, affordable medical care for everybody in the state of Oregon, and in fact, everybody in the United States of America. So what I'd like to talk to you about today are three things. I want to talk about the importance of being very, very clear about your policy objectives. And secondly, the importance of having the discipline to check means and ends periodically as you move down this process. Second, I want to talk about the fragmented and polarized and I think unsustainable nature of our healthcare system here in Oregon, which I also think offers a significant opportunity for transformational change. I know that with everything that's going on in DC, it's easy to get throw your hands up and say, why bother? But I believe that there's a significant opportunity here if we have the wisdom and the courage to grasp it. So I want to talk about that, and then I want to talk about, well, actually, I want to make the case that the overarching challenge facing our healthcare system is not, in fact, how the system is financed and organized, as important as that is. I think the overall challenge is the total cost of care. And regardless of what kind of plan you come up with, unless we can effectively address the total cost of healthcare in Oregon and in the country, we're going to be rearranging the deck chairs on the Titanic. So let's start with the policy goal. The Roman senator Seneca once said, "No wind is the right wind if you don't know what you're saying." So the question I want to ask you at the beginning here is, the universal health plan a means to an end, or is it an end in itself? I would argue that it's a means to an end. We may not agree on that point, but my North Star, the belief that's guided my engagement in health policy in this state for the last 30 years is that the purpose of our healthcare system is not simply to finance and deliver medical care. The purpose of the healthcare system is health, to maintain, restore, and improve health. So in other words, healthcare is not, it's a means to an end, it's not an end in itself, right? It has no intrinsic value outside its relationship to a positive health outcome or to alleviate pain and suffering, except as an economic commodity. And if we believe that the overarching goal is health, then we need to be aware of the fact that among those things that have the greatest impact on lifetime health status, healthcare is a rather minor contributor, right? Far more important are things like healthy pregnancies, stable families, good housing, good nutrition, safe neighborhoods, economic opportunity, education, etc. We know, for example, that 85% of what we spend in our healthcare system is spent on chronic illnesses, the vast majority of which are preventable or modifiable, and most of them flow from a short list of risky behaviors, smoking, sedentary lifestyle, poor nutrition, excess use of alcohol and other substances. And most of those risky behaviors can be traced back to stress and poor nutrition for the mother, both before conception and during pregnancy. Now, I don't think that it's the primary responsibility of the health system to address these social and economic determinants of health. That's not our area of expertise. We're not school boards, we're not social service agencies or housing authorities. It is our responsibility to reduce the total cost of care, which is not only a huge barrier in terms of access to the medical system, but also undermines the capacity of our society to make these upstream investments that would make the population and individuals in that population a lot healthier. Okay. So before we do a deep dive on the total cost of care, let's look at the healthcare landscape as it exists in Oregon in 2025. It's not good and it's not very pretty. Across our state, practices are struggling to survive, many of them on quite frankly, unsustainable financial trajectories, particularly independent practices. Hospitals are in the same boat. On any given day, half of our 61 hospitals are operating in the red. Some hospitals believe that getting bigger is the solution. I don't agree with that, but that was what happened with the recently failed effort to merge UHSU and Legacy Health. I love this metaphor. Like wounded animals, these distressed hospitals and institutions have attracted predators in the forms of companies like Optum and private equity investors. And there are unfortunately those in our state who see the lure of this dark capital as a solution. And I want to assure you, at least from my point of view, that it is not. These companies have no ethical responsibility to individuals in our state or to the health of our population. Their fiduciary responsibility is to feed on the lifeblood, the revenue streams of these distressed practices and institutions in order to maximize profit for their shareholders. To these institutions and companies, healthcare is truly just another economic commodity, and that's not us. That's not Oregon. So what all this tells us is that the business of healthcare in Oregon is unsustainable. It's in crisis. I think it's at an inflection point, and that creates the opportunity for the kind of structural change that I think your governing board is seeking. And I think that the decisions we make in this regard over the next few months, the next few years, will shape the health system in Oregon for decades to come. So the challenge, unfortunately, the business challenge is being framed right now as this: the reimbursement we're getting isn't enough to cover the cost of the care we're providing, so we need more money. In other words, we're not examining the underlying business model of the healthcare delivery system. We're not examining the financial incentives or the structure of this model. We're simply asking for more money to pay for the same system. And I believe it was Einstein who was attributed to saying the definition of insanity is doing the same thing over and over again and expecting different results. But as more and more of the delivery system begin to understand and recognize and come to terms with the fact that just pumping more money to the same delivery model is not going to provide them with the long-term financial sustainability and stability that both practices and hospitals seek, there is a profound opportunity to change course. And in a real sense, there is no more money, which I'll come back to in a moment. I think we are near the end of the road in terms of an open-ended subsidy of an inefficient, hyperinflationary, overly complex system is concerned. So the point is that the work of the governing board has arrived at a very opportune point in time. But I think to be successful, to take advantage of this opportunity, your work needs to move beyond how the system is financed and organized to a direct challenge and examination of the underlying factors that drive medical inflation in the delivery model, in the business model, the financial incentives, et cetera. So to get to the root of this problem, let me make an observation. Healthcare is the only, perhaps one of the only business sectors that produces goods and services that none of its customers can afford. Now think about it. Who else does that? The only way this works economically is because the cost of healthcare for individuals is heavily subsidized increasingly with public resources. And those resources are either through direct subsidies in programs like Medicare or Medicaid, or indirect subsidies through the subsidy in the ACA individual market, or through the tax exclusion. And as you know, the tax exclusion exempts from federal payroll and income taxes the cost that employers incur to buy healthcare for their employees. Last year, the tax exclusion was a $384 billion public subsidy of employer-sponsored coverage. My point is that almost everyone in the United States relies on some subsidy to pay the cost of their healthcare, right? So if you're on Medicaid, it's state and federal dollars. If you're in the ACA individual market, it is federal dollars. If you have a commercial policy, it's your employer and federal dollars. And if you're on Medicare, it's federal dollars. The other point I want to make here is the huge role that federal funding plays in our healthcare system, which you need to factor in as you move forward. And that's also why changes in federal policy have such an impact on our ability to do things like you were undertaking here. So, as the cost of care continues to increase, both public and private payers are seeking strategies to shield themselves from the cost escalation, not by trying to reduce the total cost of care, but simply by shifting that cost somewhere else, right? So at the state level, since we have to operate constitutionally on a balanced budget, and because the cost of healthcare is also competing directly with our ability to fund education, public safety, and daycare, et cetera, we eventually will have the only option of changing income eligibility to drop people from coverage, to disable people coverage. If the federal government, of course, doesn't have to have a balanced budget, and so they are increasingly financing the cost of Medicare and Medicaid and the tax exclusion by pushing it into the national debt and leaving the cost in the bill for our kids and grandkids to pay. So I leave it to you to decide whether or not that is a morally offensive strategy. I don't think it is. And employers simply increase the cost to their employees by co-payments, deductibles, and premiums which at some point they become, for all practical purposes, uninsured, right? And then small employers who aren't required to provide health insurance under the HCA will simply drop coverage altogether. So the cost shift is a direct consequence of the total cost of care, and ironically, the cost shift actually increases the number of people who are uninsured and underinsured, which further destabilizes hospitals and institutions. It's a vicious cycle. Okay, so let me try to unbundle all of this. It's very complicated, and I think that at least for my simple mind, it's easy to think about the healthcare system in terms of 6 questions or variables. So the first is the total cost of care. That's the amount we're paying, and it's not really a variable because it keeps going up. Then who is covered or eligibility? What's covered will benefit, how much is covered, and it's how much the individual has to pay as opposed to the subsidy. So this shows up as co-payments and deductibles. How much is paid, that's how much are we paying providers to buy that care, and then how much is borrowed. Now, because at the state level, we can't deficit fund, we actually have five variables here. But as I said, in the state of Oregon, for the last 50 years, the cost has gone up, not down. And so we really have 4 variables that we have to play with here. Okay, so since the states have to balance their budgets, right? And since the cost of healthcare at the state level is increasing faster than our ability to pay for it, it creates this hydraulic relationship between these 3 variables. So if you increase eligibility to cover more people in a zero-sum budget, which is what the state operates on, you have to reduce benefits, increase co-payments and deductibles, reduce provider reimbursement. By the same token, if you increase benefits, you will have to reduce coverage. You'll have to increase co-payments and deductibles or increase reimbursement. So those are the variables in the zero-sum budget. Those are really the only choices that you have. And those choices are going to be answered either implicitly or explicitly in the plan that you produce. So right now, from what I read, it looks like the answer to the first question, who is covered? Everyone. What is covered? I'm going to say everything tongue in cheek, but it's a pretty rich benefit package that you described there. How much is covered? All of it. And I'm not sure what the answer to this question is, although I do know there were some comments about a uniform fee schedule or a global budget. My point is that none of these answers directly address the total cost of care. Certainly, there will be cost savings from reducing administrative complexity in the plan as it stands today, but that's only one component of medical cost inflation. The real inflation is inside the delivery model itself, perverse financial incentives, poor care coordination, wide clinical variation, over-treatment, low-value care, and of course, overpricing, not to mention our failure to invest in the root causes of chronic diseases that drive most of the cost in the healthcare system in the first place. So meanwhile, the cost of healthcare continues to go up. And you see the significant increases in year-over-year premiums over the last 15 years. It's a 90% increase in the last 15 years. And look at the national debt, 156% increase, over 90% just in the last 10 years. And that's troubling because the US debt to GDP ratio is now 134%. That is, our debt is 134% bigger than the economy. And we're reaching a point where this will have a huge devastating downward drag on our economy. The worst, of course, would be defaulting on the national debt. So as the total cost, I guess my larger point for you this afternoon is that as the total cost of care continues to increase in a zero-sum budget at the state level, it will, the hydraulic relationship will undermine quality and access in any health plan that we produce. And it will continue to undermine the fiscal stability of the healthcare system itself as an economic entity. So the bottom line, in my view, is that we've got to come to terms with the fact that increasing funding for the current system is no longer an option. The total cost of care has outstripped the ability and maybe even the willingness of employers and of the public sector to continue to finance it. And if you don't believe that or don't want to believe that, where do you think the money's going to come from? Right? It's not an insignificant question. It's not going to come from individuals. They can't afford it already. And that's what health insurance is for, right? But having health insurance doesn't mean you can pay your bill. As we all know, the inability to pay a medical bill is the leading cause of individual bankruptcy, and the vast majority of people who go bankrupt because of medical debt are in fact insured. It's not going to come from the government. States don't have it. A revenue forecast yesterday is down $500 million, and states are already in a position where we are competing directly with the increase of cost in healthcare, funding education and early childhood investments, and all those other things that are critically important to our society, particularly in terms of reducing healthcare costs long term and improving the health of the population. And anybody who expects a significant increase in federal funding is just engaging in magical thinking. That's not the direction we're going right now. The Trump administration is going in the opposite direction. But to me, even more, and more important, is a growing part of the healthcare budget today is already being borrowed from our children. Medicare, Medicaid, and the tax inclusion are huge drivers to the national debt. And it's projected that Medicare and Medicaid spending will increase 78% over the next decade. The point is, we cannot borrow our way to a sustainable healthcare system. It's not these commercial payers. And they're not going to keep paying for this either, at least in the long run. The ACA market is already unaffordable for a lot of people who are in it, as is the small group market, where the vast majority of Oregon employers buy health insurance for their employees. We're going to see another rate increase this year, 8.5% in the ACA market, 12% in the small group market. And anybody who believes that employers are going to just passively accept double-digit year-over-year rate increases is living in some different reality. So my message to you this afternoon, to summarize it really quickly there, looking forward to engaging in the conversation, is this: notwithstanding the lead action approach that the Trump administration is using on federal healthcare funding, I think we still have the opportunity to shape our own future in this state. A significant opportunity. But I think the success of that effort is going to depend on a large degree on the ability to actually address the drivers of the total cost of care. As we talked about before, simply relying on administrative savings and then business as usual across the delivery model, I don't think is going to get us where I think we all want to go. And I think what's primarily missing from the health conversation in Oregon today is a clear, widely supported vision of where we want our healthcare system to be, let's say in 2030. The values we want it to reflect, the outcomes we want it to produce. What's missing is the destination. What's missing is the end. And if we can agree on that, then we can turn our efforts to means, which is how we get there, what we have to do together, what are the steps we have to do together as a state, as an industry, as consumers, to get to that healthcare vision that we want for 2030. So I think that we're at a really important point in Oregon and in our nation. We're at a point where we have to choose. We have to make an explicit choice. Are we going to continue to be apologists and passive victims of the status quo? or are we going to become proud architects of a new and better future? And I know Oregon as well as anybody, and I know a lot of people sitting around that table, and I know we're gonna choose the latter course. Thanks.
Thanks, Governor Casabra. Do you want a quick introduction? Do you want a quick introduction of our?
Oh, yeah, that'd be great, yeah.
Yeah. Do you want to go ahead and start?
Sure. Hello, Governor Michelle Glass. I'm a member of the board for public engagement.
Amy Fellows, you know me,
See it.
we can do better
We can
when
do
we
better.
started. And also part of the community engagement and communication committee.
Bruce.
Wait a minute.
I'm Judy Richardson. I'm the vice chair of this board and I sit on the operations subcommittee as well. You know me, Helen Blanca.
Jimmy G, I listened to your speech twice at OSU, and also faculty member at OSU.
Cheryl Ramirez, and I'm the chair of the Finance and Revenue Committee.
Mary Lou Henrich.
That's a big one.
She loves it. Mary Lou Henrich, been around. Finance and Revenue.
We already met, the executive director. Isabel Kim.
Isabel, I'm the executive assistant supporting the board. Hi, I'm Kim Yee, I'm the senior policy advisor.
So I think we have a few minutes for questions. If anyone has questions.
Me? Okay. One of the things that I think is a problem, that we continue to talk about the cost of healthcare versus the charge of healthcare. I think they're different. And the fact is that when we keep talking about costs, we really need to look at how are these charges, what are they made up of? And how do we get a handle on that? Because years ago, when we were starting Care Oregon, I remember asking my CFO, who came from one of the health systems, you know, is there any connection between what you're charging on the charge master versus what it really costs you to do it? He laughed at me and said, really? No, maybe 50 years ago, there was some kind of a cost study or, you know, something like that. But that just kind of rings back in my head constantly. It's kind of, what is it that makes up these?
Yeah.
You know, quote, and we just, the cost, but it's like, I don't know that anybody's really looking deeply at, you know, where are those costs? And so I'm with you on that it can't be. And I also remember Jack Friedman saying 15 years ago, it's something that one more cent that we spend on care is immoral.
Yeah.
And I talked to him the other day and I said, Jack, I remember that. And he goes, yeah, and we're stealing from our children. So I mean, I'm totally with you on this, and this is a huge issue. And I don't disagree with anything you said,
Oh,
but it is.
I think getting into a focus on the total cost of care, you cannot avoid that question. And I've had this conversation with actually quite a few hospital CEOs in the last couple of months. Bruce actually has been involved in this as well. So if you look at the statement, the payment we're getting doesn't cover the cost of the care we're providing. Assumes that there's some clear agreed upon cost of care.
Yeah.
If you look at colonoscopies just across the Portland area, they vary by about 300%. In some medical clinics, multi-specialty clinics, the use of upper endoscopy for gastric reflux disease varies 40% within that very clinic. So I think that as you think about financing, or you think about the financial incentives moving away from fee for service, putting more towards a global budget that's linked to outcomes and quality, it is going to be absolutely necessary to bring those costs out of the system.
Yeah.
I studied a lot about your early leadership in the late 1980s to develop the Oregon Health Plan. And from what I learned, the initial plan was very ambitious, including through different methods to provide universal health care.
Yes, it was.
And so my question for Governor Kisaba is, based on your experience from that era, what are the important lessons you can share with us today?
So just for those of you who weren't there, we passed the health plan in 1989. We also passed, I think it was 935 was the bill, but it was an employer mandate. And the idea was to mandate the minimum level of coverage for the private sector as whatever we decided to fund through the Oregon Health Plan. So the idea is we shouldn't be able to mandate coverage requirements on the private sector. We weren't willing to provide them for people who were, so it was treated as to create a floor. And because it had a large group of people, not just the Medicaid population, was to create incentives to make sure that that floor was robust, right? And then we needed a risk waiver. We couldn't get an risk waiver for that, right? So that was how that would hung up. So I guess what I learned from that is if we want to get, so first of all, if you look at that slide we had on how healthcare is subsidized, we're moving towards a single payer system anyway, as the population ages, et cetera. So the question is, what is the political strategy to get from here to there? And I don't have the slides. You want to put it there?
Yeah.
Yeah, just a second. I actually have a slide to go.
Oh, it's got a slide on this.
It is based on what I've learned, and it's based on politics. But I think you and I would agree, most of us would agree, and actually Helen and I were talking about this yesterday, that healthcare should be a public good.
Yes.
And if we're talking about health, so should housing, so should a good job, so should good nutrition, so should daycare, right? So it's really about getting the politics there, and yes, the one politician says, ooh, I can see you all. And this may have some utility. I'm not expecting you to agree with this approach, but maybe it's just something to think about as you try to figure out the moving forward and how you get from here to there. I mean, I think if we were starting a new system today, I think we would have a single payer system. You know, I think that's just, it's a more rational way to do it. Unfortunately, we're not starting over again, so you've got some deeply entrenched players involved that are a little bit problematic.
Yes.
Right.
I might need some time support.
Right. Actually, if I get close to electronic devices, they tend not to work.
Thank you.
Okay.
Since I can see.
Yeah. Who we got back here?
Oliver Dawkins.
Oh, yeah, yeah.
Hi, Daniel Lees. Over.
Good to see you. It's been a while.
Are you ever able to like use an external USB to upload slides?
I've not tried that.
I think it might be the government thing. But our government, it may not be letting me use
Well,
your.
I can describe it.
Sorry, people.
Actually, go back to the substitute. You guys know those slides?
Oops. Yeah.
Back to the really slide, as you know, slide.
Oh,
Yeah, okay, yeah, this guy could. Sharing that project to there.
Yep,
There we go.
there we go.
Okay. So I guess I'm not allowed to leave this because it's a public meeting and walk over here.
Oh, you can. No.
See you over here. So
They can see you everywhere.
if you look at this, imagine that we reorganize this into 3 pools. So this would be pool 1, that is a direct public subsidy. And this would be pool 2, that is a direct public subsidy. All of this is an indirect public subsidy, right? So what if we were to then start out by expanding the CCO model, uniform fee schedule, a global budget index to a sustainable growth rate tied to quality and outcome metrics, to the ASA individual market, to PEB and OEB, and to the small group market. And we get a Medicare waiver to do essentially the same thing. If you do those things, you have 75% of the Oregon population in a model with a uniform fee schedule, with a global budget that fundamentally changes the incentives. What that's going to do is leave the only place for cost shifting onto this market that's protected by risk. And it's my belief that, first of all, if you get 75% of Oregonians in that model, that would be a win all by itself. But secondly, I don't think it's going to take long until these large group market people and self-insured are going to say, you know, we really don't want that cost shift coming our way. We're going to actually try to get into some similar model. That's the moment at which I think you can move to something like what you're talking about. So I think it's a couple of steps. This would be the first step because we can regulate the individual market and the small group market and the individual market. And the problem with the ACA market, which I think is one of the hardly unfinished business of the ACA, is have no fee schedule. It's the only heavily subsidized, publicly subsidized market with no fee schedule. Medicare has it, Medicaid has it, TRICARE has it, the VA has it. And so people in that market, when they get off Medicaid, they can't afford it, right? So you, and small groups, small employers would, I think, love this because actually they're having trouble providing that insurance, which is really important to attract and maintain workers in a tight labor market. So I think what I learned from that is it's really hard to go from here to there in one step. The canyon is just a little bit too wide. So you need 2 or 3 bites, but you have to have a clear idea of where you want to end up so that the individual steps you take this session and next session are all moving towards a common objective. And I think if you look at the healthcare bills the last 3 or 4 years in the legislature, there's a bazillion of them, but they're dealing with little pieces of the problem. They're not necessarily building blocks to get to a larger goal, which is why I think your group could provide significant, could contribute to this vision of, let's just take 2030, let's take 2032. Took us 7 years to go to the moon. We could probably figure this out in 7 years. So what does that look like? And then walk back from that. It's kind of a retro design exercise of means follows function, right? So where do you want to go, and then break it down into a few steps. Does that make sense? Does that help? Yeah.
In your total cost of care diagram, where you show the hydraulic systems and what needs to go up and down, you know, as things shift on a state level. We got rid of the borrow, we can't borrow because we're a state level. And I think this group would all agree that who is covered is not an option. We are gonna cover everybody. So that leaves, you know, what is covered in terms of benefits, how much of the care is covered, whether or not there are co-pays, and how much we pay providers in that system. Those 3 hydraulics to play with. I wonder if you can give pros and cons of what you'd advise us on of like, if our choice is between reducing, I know the Oregon Health Plan, for instance, when it started, like it went with the prioritized list model. So like, if we run out of money or if there's limited money, the place where we're gonna cut is what's covered, right? Like, we're gonna reduce our benefits rather than reduce payments to providers or reduce who's covered. That was the choice made in the Oregon Health Plan. So pros and cons of that model versus should we think about co-pays as a better strategy than reducing benefits or reducing payments to providers?
Okay, so let me just, that's a really good question. So let's assume that we're gonna keep everybody covered.
Yeah.
We are going,
Yeah.
we're not throwing it off.
Right.
Because they're gonna get care anyway in the ED. right?
Yeah.
So let's start with the Oregon Health Plan first, because I think it's really important to remember that what we were trying to do was not basically ration care through the benefits. We were trying to create an accountable model so that when you had a revenue shortfall, you couldn't implicitly ration people by cutting eligibility or just cutting reimbursement to the point that people wouldn't see Medicaid, right? So there's nothing that says that if you have a revenue shortfall, you know, you have to cut the benefits, but you got to pay for it some way. You can't do the implicit rationing. So let's remember that. I do think at some point you're going to have some tool like that, because if you're operating on a global budget, there may be some cure. Let's say if there was a cure tomorrow for lung cancer or breast cancer, and it costs $10 million. At some point, something else has got to give because you're in that box. But that box is really important to recognize. So, you know, there needs to be at least some place you can have a public discussion about this and what the trade-offs are as cost goes up, which I think puts more pressure on reducing the overall cost of care. That discussion in itself. In terms of provider reimbursement, what we did with the UHP is we basically said, once the list is developed, we're going to give it to an independent actuary, and they're going to determine the cost of providing each element on the list. Providers and consumers all had input into that. The idea was to not make that a variable anymore. I think a much better way to do it, and what we didn't do with the Oregon Health Plans, we didn't look at the total cost of care. We assumed that the delivery system is just the same, right? So I think that if you move to a global budget, and it's got to be linked to quality outcome metrics, and it has to be linked to some kind of sustainable growth rate, which maybe we should talk about, which is, there are many components in the cost of care that aren't related to clinical care, labor being one of them, for example. That, and a uniform fee schedule, that does deal with the reimbursement problem, makes it very transparent. And I think the starting point of the fee schedule, whatever that's going to be, probably originally negotiated. The real cost savings, we saw this with the CCOs, is on lowering the trend rate. So if you have a health plan and they know they have to operate within this budget, they know it's not gonna change. And they can't cut people, and they can't cut benefits, and they gotta make quality outcomes, that creates the incentives to actually look at the efficiency, the waste, low value care, and low utilization in the system. Is that what we were talking about? How much is, well, on the just one point on the co-pays and deductibles. As a general rule, I think below a certain income level, those are clearly a barrier to care. If you were to think of co-payments, though, and maybe you have two choices of drug that are equally effective, and one's a generic and one is a brand name drug or specialty drug, you might want to put a copay on something like that. I mean, I think maybe there's a use for copays, but not as a just to get access to care, right? So I think there's a lot of tools available to us. And the interesting thing, some conversations that Dr. Goldberg and I have been having, there is a growing awareness, even at the hospital CEO level, that this system is not sustainable. So I just think there's an opportunity for probably in the next, 12 to 18 months.
One of the things, I totally agree that the best way to focus on the total cost of care and to control that cost is setting the global budget and operating within that. So my question for you is, as we're putting together this universal health plan for the state, where do we set that global budget? Is it the state that holds the budget and the risk? Is it some local entity that does that? What are your thoughts about where to sort of implement that global budget?
This is a really good question. Actually, I talked about this, Helen and I talked about this a while back. So I think there's the devil's in the details, right? So I mean, I think knowing where you want to get going and then sort of asking whether these different strategies get you there or don't get you there, gives you kind of a lens to look at these through. I think there's a question of attribution as well. There's a question of risk adjustment as well. I think ideally, and again, I'm not an expert, this is where Jack Friedman would be really nice to have in the room. I think ultimately, we want the delivery system to manage the risk. We want the providers to have upside and downside risk. And let me give you the example Jack uses is that the Providence Health Plan, when he was running it, they get a certain amount of money for the health plan. He would allocate, I'm making these numbers up, $400 or $800 to primary care, $200 to specialists and the rest of hospitals. So if the primary care physicians can reduce soft hospitalizations, and maybe you didn't really need to put that person in the hospital, or unnecessary referrals to specialty care, they get 50% of the cost savings. And then it went right down the line. So it was realigning those. And I think one of the problems today is that you have in a lot of insurance companies and some health plans, they hold the risk and they manage utilization costs by prior authorization and denials, right? I think Kaiser's got it right. I mean, they have that kind of a model where the group is at risk. So, in direct answer to your question, and I'm sure this is a bias and it's not based on anything except sort of an experiential thing. I do think to the extent you can have healthcare be local, ultimately it's local. Healthcare occurs locally. It doesn't occur at the state level. It occurs in a community, in a neighborhood. And to the extent that you can have some regional entity that keeps that local flavor, that has the kind of governance board, a governing board and public input built into it, but have the risk held there. I think, I'm not sure the state's the right place to have the risk. I'm not sure what that would look like. I'm not against it, but I'm not sure. But I think it's a huge question you have to answer. It's a really important question.
Yeah, no, we're really grappling with that. It's where and how to do that. And, having the fee schedule is one piece of it, because that is gonna be a way to control costs by setting the fee, but we also know, we have some of the lowest per unit costs for healthcare in the country, but we have the most units. So our healthcare system has done very well at, if we hold steady on the cost, we just.
You gotta create a box.
Yeah.
Yeah, it's interesting, Amy will remember this, when we did the Archimedes movement, one of my many great statewide failures. Well, it spawned a good organization though. But we had, if you look at that, I'll actually send it to you guys if you're interested, but what we were doing is we were playing it, it was a design game, and the idea was, let's assume that Oregon had all the public dollars that are being spent on healthcare, including the value of the tax exclusion and Medicare and Medicaid, et cetera, and it's gonna be in a big pot called the Oregon Health Fund or something. And then we were going to develop a uniform benefit using our prioritization process or something like that. Everyone was gonna get it at no cost, right? Just it's pretty much. And the care was gonna be delivered by local risk-bearing entities that did not exist in 2007, nor did we have a waiver that would allow us to do that in 2007. Now, CCOs, I'm not saying they need to stay the same, but they are local risk-bearing entities. We have something like that in place. We have that infrastructure in place. And through 1132 waivers and a Medicare waiver, you could probably do that. So, you know, I just think we should look, we have a lot of infrastructure in place that maybe needs to be redesigned, but I'm not sure it needs to be reinvented. And 12 years of experience with these.
Thank you so much, Governor Kittel. We really appreciate you being here. I want to respect everyone's time. We said we'd wrap up by 2. I think Governor Kittel is able to stay for a few minutes if you want to stay and chat more informally. But I think it's time to bring this meeting formally to a close. I want to thank all of you for your engagement and your participation, especially Judy for her
Yes.
great facilitation. Shout out to our staff, Kim and Mimi and Isabel for coordinating the meeting and making it happen. And we have marching orders for June, so we will send out some information to you and plan to see you in June. Thank you all so much for being here.
Thank you, Helen.
Oh, yeah. Oh, yeah. You guys-
It's the second time.
Let me suggest.